Hello everyone, welcome back to our third Virtual Symposium edition organized by INSER. In this time, we are going to talk about the preservation of infertility and alternative for the present and the future. We hope to be your allies in this moment and the future to come. Enjoy our symposium.
For INSER Group and our international department, it's been really important throughout this year working together with our international allies, with those gynecologists that are in different cities all around the world, with whom we work together with the objective of helping our patients succeed in their dream of becoming parents, or in this case, succeed in their dream of preserving their fertility. So we've done several events training these gynecologists in basic aspects and new and important information about fertility treatments. This time, we're going to be talking specifically about fertility preservation. It's a really important aspect that patients are looking for and coming to our offices asking for possibilities of preserving their fertility in the era in which they have to dilate that fertility because of professional, academic aspects in their life. Of course, there's also a subject of many patients with oncological or diagnoses like endometriosis that need to preserve their fertility because of a medical indication. So in this event, we're going to be talking about fertility preservation. We're going to give you nice information about how to do it, medical information about what are the indications, what are the protocols, legal information about what happens with this kind of treatments in different countries and different possibilities in terms of logistics and practical applications. So we're really interested in making these ties stronger between our international allies through information, through medical knowledge, and through medical training. So I hope that you have a wonderful meeting, that you learn a lot, and that we can keep on working together on behalf of making the dream of our patients come true.
Hello, thank you for being with us today. It's a pleasure to have you here in this third symposia of INSER for our international partners. My name is Juan Luis Giraldo, MD. I'm a gynecologist, OBGYN, and I'm an international director of INSER's international department. So in this next 20 minutes, we're going to talk about a really interesting subject: fertility preservation for women, the new female frontier. Every gynecologist today needs to know basic aspects about fertility preservation to be able to counsel his patients or her patients appropriately. So I hope this short talk gives you those basic issues and concepts about fertility preservation that you can use for your patients in your clinic or hospital. These are my disclosures. Of course, I'm INSER Group partner, and we do fertility preservation on a regular basis. There's two big indications for fertility preservations: medically indicated fertility preservation and elective fertility preservation. We're going to start talking about medically indicated fertility preservation. There's lots of conditions that are good reasons to think about and to perform fertility preservation in our patients. First, our oncological pathology of patients that are going to be taken to radio or chemotherapy that's going to affect their ovarian reserve, patients with severe endometriosis, with ovarian compromise, with endometriomas that we today know that diminish ovarian reserve, patients with genetic disorders such as Turner syndrome, usually mosaic Turner syndrome, that have, well, early ovarian failure, so that we can preserve that fertility for those patients before they get to that ovarian failure. And of course, patients with BRCA1 mutation or BRCA2 mutations that can be recommended to have oophorectomy during their reproductive life. Also, patients that have a risk of premature ovarian failure related to Fragile X syndrome are candidates for fertility preservation. Patients that are taken to surgery for oophorectomy due to malignancies in their ovaries or their reproductive tract, or benign pathology as endometriosis or pelvic abscesses and infections. Transgender medicine is also an area we should recommend fertility preservation. And something that's a little bit more controversial, women with low ovarian reserve evidenced by low AMH values. But cancer is becoming a real issue for us that work in reproductive medicine. In 2018, GlobalCan reported that in that year, 8.6 million women were diagnosed with some form of cancer. Most of them, the biggest part, with breast cancer, but also a good portion of those patients with cervical cancer. And the thing is that cancer incidence is on the rise in women around the world. If you can see all these countries, the incidence of cancer in women is increasing year by year. The dotted line on the right side of the screen shows the tendency, and the blue line is Colombia. Our incidence is increasing constantly. And the purple line is the USA, where the incidence is also increasing a lot. In Colombia, just in a period of 10 years, the number of cases of women newly diagnosed with cancer went from 40,000 a year in 2015 and will be 60,000, almost 60,000 a year in 2025. In a period of 10 years, it increased 50%. But many women, of these women that are diagnosed with cancer, are in the reproductive age, women under 45 years old. Almost 10% of women with cancer are in reproductive age. And approximately 100,000 women in reproductive age will be diagnosed with cancer this year in the USA. 1% of all the cancer diagnosis is made in children. And in these cases, of course, fertility preservation is something to talk about. But as cancer incidence goes up, the cancer mortality goes down in women. Medicine has lots of advances, fortunately, and we see that these patients, this woman diagnosed with cancer, survive more to cancer each day. As you can see in these countries, and the dotted line, that's the tendency, and the blue line, that's Colombia, and the purple line, that's the US, the mortality is constantly diminishing. And that's why 80 to 90% of adolescent patients and young adults survive cancer in Europe and in the USA, but of course, with consequences in their fertility prognosis. In the last 5 years, overall mortality of cancer has diminished constantly 1.6% per year. So we can conclude several things from this. First, that the number of women with cancer is on the rise. Second, that the number of female cancer survivors is on the rise as well. Third, that cancer treatment focus is increasingly on quality of life after cancer because we have more survivors. And finally, that fertility is a fundamental aspect to consider when talking about quality of life. So when we see oncological therapy, which ones are the most deleterious or which ones affect the most the ovarian reserve? Mainly pelvic radiotherapy. That's the biggest one. And on the second place are alkylating agents in chemotherapy, just as cyclophosphamide. So those two are the big enemies. And what does chemotherapy does on ovarian reserve? Well, the induced damage in the ovary by chemotherapy is caused by the loss of primordial follicles by apoptosis, by the enhanced follicular atresia, by the inflammation and damage of the ovarian stroma, and by the damage to the intra-ovarian vascularization. But there's one thing that's really interesting. Remember that chemotherapy affects and kills cells that are reproducing or growing pretty fast. So antral and preantral follicles fall into that classification. So chemotherapy goes in and takes those preantral and antral follicles pretty fast into apoptosis, into atresia. And those follicles are the ones that produce the anti-Müllerian hormone. And the anti-Müllerian hormone is now known to be one of the most important agents in the regulation of the primordial follicle recruitment. So when the AMH levels fall, because those antral and preantral follicles in that patient with chemotherapy go into atresia, the recruitment of primordial follicles increases. So we have an accelerated primordial follicle activation. And that's why we lose a lot of this pool of primordial follicle during chemotherapy in patients with cancer. But this can be a nice conclusion. Well, not nice because of what it says, but nice to get an overall idea of what chemotherapy does on ovarian reserve. After chemotherapy, a woman's ovarian reserve will behave as if she was 10 to 12 years older. We need to have that in our mind. That's why patients of 38 or 40 years old that go to chemotherapy for breast cancer, 80 or 85% go into premature ovarian failure after that chemotherapy. But what about elective fertility preservation? This is what women today are living. They're living in a dichotomy. They don't know if they want to be first good moms and then good professionals, or first good professionals and then good moms. Usually those two conditions don't get along each other that well. So it's a really difficult condition. That's why we're seeing this each time more oftenly, okay? And it's gonna be knocking on our doors in the near future. Because childbearing age in women worldwide is increasing constantly. If you see in Europe, in the last approximate 20 years, the average age of childbearing for women has increased almost 4 years. 4 years in the reproductive span life of a woman is a really, really important time. And this is no secret for any one of us in this meeting. Fertility has consequences regarding age. Women acquire their maximum fertility potential between 20 and 25 years old. At that point, they kind of stabilize up to 30 years old. After 30 years old, fertility potential starts to diminish. It's not that noticeable until 35, but after 35, that diminish in fertility potential starts to decrease really fast. And after 38, well, it plunges down. And otherwise, on the other hand, the possibility or the spontaneous miscarriage rate increases definitely with age. So it definitely affects fertility potential and the ability of women of advanced reproductive age of finally having a live newborn. But since we're seeing that women of higher reproductive age are trying to get pregnant, so of course, a percentage of those women are going to get pregnant spontaneously. Which ones? Probably the ones that have a better ovarian reserve at advanced reproductive ages. Those are the ones that are going to get pregnant spontaneously. So their daughters are probably going to get from their mothers genetically that capability of having a good ovarian reserve at advanced reproductive age. And they're going to get pregnant at advanced reproductive age, and they're going to have daughters with good ovarian reserve at advanced reproductive age. So this is how evolution works. Okay, so finally, the window of fertility potential of a woman, it's going to be expanded through the years as we go up in the childbearing age average worldwide. But how long will this take? So this group in McGill University in 2011 did a really interesting research. They tried to detect the speed of biological evolution. So they used a really interesting model. They used fungi that reproduce in a matter of hours and therefore allows you to see generational change much faster than any other species. So they got a robot that worked 24/7 for several months, generating an environmental stress to a fungi culture by increasing the salt concentration. And they saw and they concluded that the evolutionary changes were verified to adapt to the environment in approximately 50 to 100 generations. So that fungi could develop the ability to survive to those hostile environmental stress conditions after 50 to 100 generations. So if we extrapolate that to humans, in humans, each generation is considered to be approximately 25 years. So that would mean that for a woman to be able to start having, well, good fertility rates at advanced reproductive age, it will probably take 1,250 to 2,500 years. Not practical. So that's why we need to develop strategies for fertility preservation. And we've done that. If you see from 2012, the number of cases of fertility preservation in the US reported by the ASRM was 3,000 per year. 4 years later, in 2016, that number increased 300% to 9,000. And in 2020, ASRM reports approximately 24,000 cycles of fertility preservation with oocyte or embryo banking. So it's increasing definitely. It's something that's permeating to our society. And this made a whole big difference. Why? Because we've been cryopreserving cells for many years now. The first sperm cell cryopreserve was 1953. But the classic cryopreservation methods are done by slow freezing, by turning the tissues into ice. And the big problem is that the ice that forms inside the cells have sharp edges that can damage the organelles of the cell, mainly the meiotic spindle. So the secret for slow freezing for conventional cryopreservation is to dehydrate the cell. Meanwhile, the temperature is taken down slowly to avoid the formation of those ice crystals inside the cell. So the cells that have the biggest quantity of liquid inside are the cells that give us the more difficulty to be able to be cryopreserved. And well, it happens that the egg is the biggest cell in the body. Of course, the one that has the most liquid inside. So oocytes have been very inefficiently cryopreserved with conventional slow freezing techniques, with very bad survival rates, until really bright groups decided that they were going to try to avoid those ice crystal formations inside the cells. They were going to turn those eggs into glass instead of turning them into ice. So vitrification was formed. and was born. And vitrification consists of putting the cell in high concentrations of cryoprotectants and plunging the cell, the oocyte, fast into liquid nitrogen to have a really fast decrease in temperature. So you vitrify the eggs that way. And when you want to use those eggs, you warm the eggs. And the survival of oocytes with vitrification is extremely good, between 85 and 90%. So it made a big difference in terms of female fertility preservation. Actually, the first baby reported with slow freezing conventional techniques from a frozen oocyte was in 1986. But up to 1996, the results were pretty bad. And many groups attempted to obtain pregnancies from these eggs and couldn't make it. The first baby with vitrified oocytes was 1999. And basically all groups report now oocyte survival after vitrification and warming around 85 or 90%. Actually, in 2013, ASRM removed the experimental label for oocyte vitrification based on similar results obtained in terms of pregnancy rates with vitrified versus fresh oocytes. In 2014, ASRM and Canadian Fertility Society introduced the concept of elective oocyte preservation without medical indications. And today, most of the oocyte cryopreservation or fertility preservation cycles are done for elective purposes or for social reasons. Only 12% are done because of a medical indication. At INSER, we see exactly the same. In 2020, 41% of our fertility preservation cases were due to medically indicated fertility preservation. But 2 years later, that 41 turned into 23%. And most of our cases now for fertility preservation are elective fertility preservation cases. Fortunately, we learned that the ovary does not have just one wave of follicular development during the menstrual cycle of a woman. We now know that it has 2 waves or even 3 waves. So today we can start control of our hyperstimulation protocols or ovarian stimulation protocols with GnRH antagonists at any day during the cycle. That's called a random start. As long as we're not gonna do a fresh embryo transfer, of course. But this allows us to start that patient with an oncologic diagnosis that needs to start her treatment pretty fast. We can start her right away, independently on the day she's on her menstrual cycles. And it's only gonna delay her treatment for 12 to 14 days. And we know that pregnancy rates are similar today with cryopreserved or vitrified eggs or vitrified embryos. So we can choose whatever we want. Of course, embryos have some ethical implications because it's not the same thing to discard eggs than to discard embryos in case those are not going to be used in the future. And today, the conclusion in egg cryopreservation is that the clinical pregnancy rate is going to be 6% per vitrified egg. So each vitrified egg is going to give us a 6% percentage of pregnancy rate in women under 35. So if a woman has 15 oocytes, her cumulative pregnancy rate is probably going to be around 85%. So it's a good chance of making it. And Dr. Coble from the Instituto Valenciano de Infertilidad published in 2021 this interesting retrospective paper that included approximately 1,500 women that had electively cryopreserved eggs for fertility preservation. And this woman came back to use those eggs to get pregnant. And something really interesting appeared. If women were younger than 35 years old and they had at least 15 eggs, their cumulative pregnancy rate was as high as 85%. But if the patient was over 35 years old and had, let's say, 10, 11 eggs, her cumulative pregnancy rate was 35%. So there's a big difference between doing elective fertility preservation with vitrification of your oocytes if you are under 35 or over 35. We now have good tools to calculate the possibility of a patient of having a live newborn with fertility preservation techniques, with vitrification, with egg vitrification, and these tools give us that possibilities according to age and the number of vitrified eggs. But if there's no enough time to vitrify eggs, you always can freeze ovarian tissue, mainly in patients that need to start their oncological treatment right away for some reason, or in prepubertal girls that cannot be stimulated. So in that sense, you can go and through a laparoscopy, you can get small fragments of the ovarian cortex to cryopreserve. As you see here, those are really small portions of the cortex of 1 millimeter, really thin pieces of ovarian cortex, and they can be cryopreserved usually by slow freezing techniques. And when that patient has gone through treatment and is declared healthy and a survivor of her oncological diagnosis, she can have an ovarian cortex transplantation. And that ovarian cortex transplantation can be done in the ovarian medulla, or it can also be done in a peritoneal pocket orthotopically in the pelvis, the pelvic wall of that patient. But everything in medicine has pros and cons, as everything in life. So what are the pros of ovarian tissue cryopreservation? First, there's no delay. You can do that in 1, 2, 3 days, and you don't have to delay the initiation of the oncologic treatment in that patient. Second, there's no need for controlled ovarian hyperstimulation. You don't have to do ovarian stimulation for that patient. Third, you can use it in prepubertal girls that cannot be stimulated in terms of COH. And fourth, that it not only restores fertility, but also restores endocrine function. That patient is going to have spontaneous ovulation again, and will have menstrual cycle again, and will have endogenous estrogen production again, with all the positive aspects that can be related to that endocrine function. But the cons are that there's a metastasis risk in that transplanted tissue, mainly when the oncological diagnosis is leukemias, breast cancer, or ovarian cancer. And of course, you're going to need 2 surgical steps, one to get the cortex and one to transplant the cortex back to its place. Approximately 50 to 90% of the follicles are lost in this transplanted tissue. And that we lose those follicles basically due to ischemic damages and hypoxia prior to established angiogenesis. Nevertheless, more than 200 live births after orthotopic ovarian tissue transplantation has been reported up to 2021. Ideally orthotopic. It's had the best results. Pregnancies can be obtained spontaneously or through IVF. Most of the pregnancies that have been reported have been spontaneous pregnancies. And the ovarian tissue transplantation is said can be done 2 years after treatment completion due to decreased risk of recurrence in that patient. Ovarian function restitution is achieved in almost 95% of the patients. Most of them have restored ovarian function, and usually during the first 4 to 5 months after ovarian tissue transplantation.
Ahí está cargando por ahí.
Lo que se llaman esos óxitos, porque no pueden darse ni siquiera
Estás
esas
tú,
2 semanas.
estás tú, tu carita.
And most of our cases now for fertility preservation are elective fertility preservation cases. Fortunately, and we'll have menstrual cycle again, and we'll have endogenous estrogen production again, with all the positive aspects that can be related to that endocrine function. But the cons are that there's a metastasis risk in that transplanted tissue, mainly when the oncological diagnosis is leukemia, breast cancer, or ovarian cancer. And of course, you're going to need 2 surgical steps. One to get the cortex, and one to transplant the cortex back to its place. Approximately 50 to 90% of the follicles are lost in this transplanted tissue. And that we lose those follicles basically due to ischemic damages and hypoxia prior to established angiogenesis. Nevertheless, more than 200 live births after orthotopic ovarian tissue transplantation has been reported up to 2021. Ideally, orthotopic. It's had the best results. Pregnancies can be obtained spontaneously or through IVF. Most of the pregnancies that have been reported have been spontaneous pregnancies. And the ovarian tissue transplantation is said can be done 2 years after treatment completion due to decreased risk of recurrence in that patient. Ovarian function restitution is achieved in almost 95% of the patients. Most of them have restored ovarian function, and usually during the first 4 to 5 months after ovarian tissue transplantation. And that ovarian activity and endocrine function is going to last approximately 5 years. After 5 years, there can be a new ovarian tissue transplantation, and there's going to be endocrine function for another 5 years. So that's a good point. And finally, almost 30% of pregnancy rate has been reported basically by experienced group in ovarian tissue transplantation. You can see here the behavior of FSH levels after ovarian tissue transplantations. As you see, most of the patients have normal FSH levels after approximately 4 to 5 months, counted from the moment they were transplanted. But also, there can be a heterotopic ovarian tissue transplantation. Most of the cases have been transplanted to the forearm or the abdominal wall. Controlled ovarian hyperstimulation with follicular aspiration and ICSI is obviously required in all these cases, and very few cases have been reported. Orthotopically has had the best results. Heterotopic is an option, but it's not as good as orthotopic. And this is really interesting. Dr. Dolmans and her group in 2021 reported that there was no decrease in pregnancy rates when the ovarian tissue freezing was performed after chemotherapy was completed. So today, it's a good practice to obtain that ovarian tissue in patients with leukemia that, remember, have a high risk of metastasis in the ovarian tissue. So it's better to obtain that tissue after chemotherapy has been completed in these patients with leukemia. Other option is in vitro maturation of oocytes. That means to do follicular aspiration without controlled ovarian hyperstimulation or with minimal controlled ovarian hyperstimulation of 1 to 3 days. Do a trigger with HCG 36 hours prior to aspiration. Culture those eggs in culture media with FSH and LH to achieve in vitro maturation of those oocytes. And these decreases the time to oncological treatment initiation because that patient can be aspirated right away or after 1 or 3 days of ovarian stimulation. It prevents also elevated estrogenic levels in patients with positive receptors in breast cancer. But unfortunately, the results are really irregular and inconsistent. You can say that the pregnancy rates with these techniques are going to be probably 50% of the pregnancy rates achieved with conventional IVF. But you can not only in vitro maturate eggs, you can also in vitro maturate follicles. Follicles that are isolated or cultured from in vitro cryopreserved and thawed ovarian tissue. And these with the objective of avoiding autologous transplantation of ovarian tissue with potential content of malignant cells. So in that case, what you do is that you thaw that cryopreserved ovarian tissue, you isolate primordial follicles from the ovarian cortex, you grow those follicles and culture those follicles in vitro until you reach antral stage. And at that point, you remove the oocyte and do in vitro maturation for oocytes until you have metaphysed 2 oocytes that you can fertilize through ICSI and obtain embryos. No pregnancies yet, but interesting for the future. So this is a fertility preservation algorithm. It's kind of simple. If you have a patient that needs fertility preservation for an oncological diagnosis, so you can go ahead and do ovarian stimulation if you have time. And you obtain oocytes, and those oocytes, you can vitrify them, or you can fertilize them to form embryos and vitrify embryos. If you vitrify embryos, when you thaw those embryos, you can replace them or transfer them to that same patient or to a surrogate mother. Or if you vitrify oocytes, you may warm those, fertilize those through ICSI, form embryos, and transfer those fresh embryos to, well, the patient or to a surrogate. Of course, if you don't have that much time, you can try in vitro maturation. That's another possibility, form oocytes and go to the same procedure or protocol, form embryos or vitrify oocytes. Or if you don't have even 3 days, you can go ahead and do a ovarian biopsy, obtain tissue, obtain ovarian cortex, and cryopreserve ovarian tissue for later autotransplantation. That can be a good option also in prepubertal girls. Of course, regardless of the technique you're going to use, there's 2 things that you can do to diminish the damage because of radiotherapy, of chemotherapy in those patients. First, ovarian transposition if that patient is going to have pelvic radiotherapy. And second, the use of GnRH analogs that diminish apparently the damage of chemotherapy to the ovaries. That's a little bit controversial, but nothing's going to happen to the patient for using GnRH analogs. Meanwhile, she's doing chemotherapy. And this is a little bit of the future. So what is on our scenery in the, well, long-term future? Probably the formation of artificial ovaries. And the formation of artificial ovaries to avoid transplanting ovarian stroma to that patient and avoiding metastasis. So in that case, the primordial follicles are obtained from the ovarian, that cryopreserved ovarian tissue, and they are placed in a scaffold of biomaterials, collagen, fibrin, and form a artificial ovary that then is transplanted orthotopically to that woman. That's going to be interesting. And the other possibility is the formation of oocytes from induced pluripotent stem cells that you can get them from mesenchymal cells, form primordial germ cells, and from those primordial germ cells form eggs. And of course, also the formation of oocytes from ogonial germinal stem cells. So those are 2 things interesting in the future. To conclude, knowledge is power. It allows us to foresee the future and prepare for it. This was said by Louis Pasteur, and I think it's pretty bright. This is our group. It was really interesting to be here with you today. Please send us all your questions. We'll answer them at the end. And well, we will be here happy to help. Thank you very much.
Hello, good day. My name is Ivan Montes. I'm a fertility specialist in INSER Bogotá, and today we're going to speak about fertility preservation protocols. In recent years, the demand for fertility preservation for oncological and non-oncological reasons, as well as personal reasons, has increased dramatically. And meeting this demand will prove a major challenge in coming years. Currently, embryo cryopreservation and mature oocyte cryopreservation after ovarian stimulation are the only methods for fertility preservation endorsed by the American Society for Reproductive Medicine. However, many experts believe that there is now enough evidence to support the use of ovarian tissue cryopreservation as a valid and effective technique for preservation of tissue instead as just an experimental approach. Of all the available means of fertility preservation, the oocyte cryopreservation by means of vitrification, that is a method where you really rapidly freeze the embryos, provides the highest yield not only for women with benign diseases or those seeking fertility preservation for personal reasons, but also for women with cancer, if the treatment of the chemotherapy cannot be postponed. Ovarian tissue cryopreservation is especially indicated for adolescents and women in whom cancer treatment cannot be postponed as or less than 2 weeks. The term ovarian reserve is typically used to refer to the population of primordial follicles. Initiation of the resting primordial follicles reserve begins in the fetus when 100 to 2,000 primordial germ cells colonize the genital regions and enter a massive proliferation process that results in 7 million potential oocytes at mid-gestation. In the human ovary, approximately 85% of these potential oocytes are lost before birth. The decline in the number of follicles continues throughout the reproductive life, during which time approximately 450 ovulatory cycles occur, with the majority of follicles undergoing atresia during the growth phase. The serum levels of anti-Müllerian hormone, which is correlated with the number of primordial follicles, but is not a direct product of these follicles, can be used to estimate their reproductive lifespan. As we can see here, I wanted to show you this graphic, and I usually use this graphic with my patients as I try to explain them all this that I have told you. That at the beginning, when she's born, she has around 1 to 2 million of eggs. At the age of the onset of puberty, she has around 350 to 450. And at the age of 25, more than half of those eggs have been used. And at the age of 30, only 12% of the eggs remain, which means that with age, this is not gonna stop, but instead is gonna decrease rapidly after 35 years of age. That's why we call advanced maternal age after 35. And the reason is because the increase of miscarriage rate and also the diminish of monthly pregnancy rate that diminishes after 35 years old to 12%, after 40 to 5%, and after 45 to 1%. And when the average onset of menopause starts, is because the ovarian reserve is less than 1,000 eggs. Fertility preservation remains a challenge, particularly in the case of hematologic cancers like Hodgkin lymphoma or non-Hodgkin's lymphoma and leukemia and breast cancer. These cancers constitute the most frequent indications for fertility preservation, since chemotherapy, especially with alkylating agents, radiotherapy, surgery, or a combination of these treatments can induce premature ovarian insufficiency in some circumstances. The ovaries are very sensitive to cytotoxic drugs, especially alkylating agents, which are likely to cause gonadal dysfunction. Cyclophosphamide is the alkylating agent that causes the most damage to oocytes and granulosa cells, and it does it in a dose-dependent manner. The pelvic radiotherapy is also known to cause premature ovarian insufficiency. Indeed, the human oocyte is very sensitive to radiation, and a dose of less than 2 GI is estimated to be sufficient to destroy 50% of primordial follicles. Ultimately, the probability that premature ovarian insufficiency will develop after chemotherapy or radiotherapy is related to the ovarian reserve. This reserve can vary enormously from one woman to the next. Fertility preservation should also be offered to women with certain benign conditions that carry the risk of premature ovarian insufficiency. Many autoimmune and hematological conditions sometimes require chemotherapy, radiotherapy, or both, and sometimes even bone marrow transplantation. Other conditions that also impair future fertility, such as the presence of bilateral ovarian tumors, severe or recurrent ovarian endometriosis, and recurrent ovarian torsion, can be related to indications of fertility preservation. The ovarian endometriomas led to reduced ovarian reserve. Local intraovarian inflammation induced the presence of endometriomas, and also has been shown as a trigger follicle burnout, characterized by activating follicle recruitment with subsequent atresia. Moreover, increasing evidence shows that performing cystectomy on endometriomas may cause considerable damage to the ovarian reserve. So fertility preservation should certainly be contemplated in case of recurrence after surgery. Turner syndrome and a family history of premature ovarian insufficiency are additional indications for fertility preservation. There is compelling evidence that certain forms of premature ovarian insufficiency have a genetic cause. The largest group of women seeking fertility preservation consists of those who wish to childbearing for various personal reasons. So usually around 20% of all the patients right now preserving fertility are related to the first malignant and non-malignant conditions. But the personal reasons, as age and postponing childbearing, are the most common causes for fertility preservations around the world. And when we speak about the fertility preservation, we usually speak about the ovarian follicular waves. And the thing is that recent research has suggested that recruitable antral follicles are continuously present in the ovaries during the menstrual cycle. And ultrasonographic studies have demonstrated that multiple cohorts of waves of 2 to 5 millimeters of follicles are recruited continuously during a menstrual cycle. A wave is a synchronous growth of follicles that have a similar diameter. Waves of follicle development have been documented in healthy women using ultrasonography. 70% of patients have 2 follicular waves, and 30% can even have 3 follicular waves. Women with 3 follicular waves may have longer menstrual cycle compared to women with 2 waves. The follicular wave that emerges in the early to mid-follicular phase is ovulatory, while the waves emerging in the luteal phase are usually anovulatory, as shown here and here. The follicular waves could be recruited by constantly high concentrations of FSH. This new knowledge about ovarian function, and in particular the theory of a multi-cyclic development of follicles during the menstrual cycle, resulted in the prospect of a new approaches to ovarian stimulation, and in particular the random start ovarian stimulation protocols, namely the administration of exogenous gonadotropins randomly on a day of the monthly menstrual cycle. In parallel with these new theories in ovarian stimulation protocols, advances in vitrification of embryos and oocytes has allowed important progress to be made towards a new concept of a total disarticulation between ovarian stimulation and embryo transfer. As a consequence, new ovarian stimulation protocols can be proposed to those patients who could potentially benefit from it. These are useful particularly in cases of oncology patients seeking fertility preservation who may present at any stage during the menstrual cycle. Adhering to the convention of initiating controlled ovarian stimulation at the beginning of the follicular phase may result in either significant delay or cancer treatments or foregoing fertility preservation because of time constraints. Of course, these new protocols may also be useful to women who want to preserve fertility for non-medical reasons, where double stimulation protocols might help with oocyte embryo accumulation. It has been suggested that double stimulation might serve as a useful strategy for poor ovarian response patients where accumulation of more oocytes in a short time could improve outcomes. So when we talk about these type of protocols, I wanted to divide it in 3 ovarian stimulation protocols for this type of patients. One is that when you have enough time, you can use the conventional stimulation protocol. But if you don't have enough time, you could do a random start protocol. And as I already have spoken, using the follicular waves means that you can start at any moment of the cycle. And the double stimulation would be, well, maybe useful in patients where the poor ovarian reserve or the poor ovarian response might be the case. So when we need to start the random start, we speak about the need to start ovarian stimulation on any day of the menstrual cycle. Doesn't matter when was the menstrual cycle. She's gonna come to us in any day of the cycle, and she's going to tell us that she has cancer and that she needs to preserve fertility because she's going to start cancer treatment. So this part of the process, the fertility preservation for cancer patients, has become essential in oncology care. Cancer treatment, especially when you use alkylating agents such as cyclophosphamide or total body irradiation prior to stem cell transplantation, is often cytotoxic and may result in depletion of ovarian follicles with subsequent subfertility or infertility and ovarian failure. The ovarian stimulation for embryo oocyte cryopreservation in postpubertal girls and women with cancer is the only technique approved, again, by the American Society for Reproductive Medicine. All other methods of fertility preservation, such as ovarian tissue cryopreservation, ovarian transplantation, in vitro maduration of immature oocytes, and the use of GnRH analogs are still considered investigational. Although ovarian tissue cryopreservation is the only possibility when the cancer treatment cannot be postponed, but this topic is beyond our lecture. Additionally, ovarian stimulation is initiated at the start of the follicular phase, but this method might require several weeks depending on the patient's menstrual cycle phase at the time of the initial visit. The theory of multiple follicular waves gives us the possibility of doing a random start. And this is an attractive approach for cancer patients. In cancer patients, there is no need to achieve synchrony between ovaries and endometrium, and there is no fresh embryo transfer, thus allowing us to do the random start protocols. Depending on the timing of presentation in relation to the menstrual cycle, we can divide it into starting the controlled ovarian stimulation in early follicular phase, which is almost as a conventional treatment or a conventional ovarian stimulation protocol. But she can also be in the late follicular phase, or as we will talk in the next slide, in the luteal phase. So when the patient comes, we can see her and do the ultrasound to see how her follicles are, in which measure are they. And you can say that the early follicular phase is when you have less than 2 follicles of more than 12 millimeters, or if the progesterone level is below 2 nanograms per milliliter. The early follicular phase, the early luteal phase is defined as presentation within first 7 days after ovulation, and the late luteal phase is presented when in the last 7 days of the menstrual cycle. The late follicular phase and the early luteal phase are the most challenging time for random start stimulation protocols. And the reason is because in those moments you actually don't know or cannot be sure that the response is going to be the adequate for the patient. So what I recommend to do is that in the initial visit you should ask for her last menstrual period. Do the ultrasound and see how the follicles are. If the patient is in the late follicular phase, well, she already has a dominant follicle, which means that you can trigger the ovulation sooner, or you can inhibit the whole process of ovulation using analogs, a GnRH analogs antagonist of GnRH to inhibit the dominant follicle. After that, you can start the gonadotropins, and you can start the gonadotropins independent of the spontaneous LH surge, because you already have stopped the dominant follicle and the maturation of the dominant follicle. On the 5th day of treatment, you can start the GnRH antagonist, and you can decide to do the trigger with HCG or analogs of GnRH, and 36 hours later you can do the oocyte retrieval, and this protocol can be used with very good results. The other protocol that we usually use is for patients during the luteal phase. And well, in these patients, the last menstrual period was more than 14 days. You see her in the ultrasound and you see that she doesn't have a dominant follicle, but maybe a corpus luteum. When you see her on the initial visit, well, you can start at any moment. At any moment. We usually recommend that if you're not completely sure, it would be better to measure the levels of progesterone to see if she already had the ovulation process. If the ovulation process has already been completed and she already ovulated, you can start at any moment the gonadotropins. Doesn't matter if it's FSH, recombinant FSH, or HMG. It would depend on the possibilities and the chances of having the medication close to and expensive, and well, the expenses for the patient and everything related to it. Some patients are recommended to use the GnRH antagonist, but even when the spontaneous LH surge has happened, sometimes at the beginning you should not use the antagonist, because the progesterone is going to do the whole inhibition process of the triggering of these follicles. And when you measure the follicles and they're below 80 millimeters to 20 millimeters, you should do the trigger. And it doesn't matter if you use HCG or analog or agonist of GnRH. In 36 hours, you can also do the oocyte retrieval. And also the results are very good. The control of iron stimulation in women with estrogen-sensitive tumors is another challenge and should be dealt with caution. This can be achieved with addition of letrozole or tamoxifen to the above protocols to nullify the effect of rising estrogen levels during stimulation. And this is very important. And it actually doesn't matter the moment of the menstrual period for the initial visit, but you should start the medication always with letrozole at a dosage of 2.5 to 5 milligrams. And this medication should be maintained through the whole treatment or the whole process of hyperstimulations, either with gonadotropins, recombinant gonadotropins, or with HMG. And you can also use the GnRH antagonist to inhibit the natural trigger, and you can do the trigger with HCG, but it's also recommended to do the trigger with analogs agonist of GnRH. This diminishes the chances of needing more timing of letrozole. And when the oocyte retrieval is done, you should measure the levels of estrogens, and when the levels of estrogens are below 100, you can finish or you can stop the letrozole. The concept of continuous ovarian follicular growth, the random start of ovarian stimulation, and the disarticulation of stimulation and embryo transfer led to the possibility of performing consecutive ovarian stimulation cycles and oocyte retrievals procedures in order to increase the number of oocytes available and possibly embryos in one cycle or in just 1 month. This is called double ovarian stimulation, and it consists of 2 successive ovarian stimulations in the follicular and ensuing luteal phase with 2 oocyte retrievals at the end of both ovarian stimulations. Use of a second ovarian stimulation during the luteal phase was first applied in poor responder patients. Kwan tested the possibilities of 2 ovarian stimulations in 2014 and showed good results in terms of more opportunities of retrieving oocytes. In these regimes, the first stimulation started normally in the early follicular phase, while the second stimulation started on the first day after the first oocyte retrieval, on which 2 or more antral follicles were identified. The first and second stimulations used 2 different regimes as follows. The first ovarian stimulation was conducted using a combination of clomiphene 25 milligrams per day, starting on day 3 of the cycles until the triggering of ovulation, letrozole 2.5 milligrams per day on day 3 for a total of 4 days, and HMG 150 units every day, starting on day 6 until the triggering of ovulation. The second stimulation was after the first oocyte retrieval provided as many oocytes and blastocysts as obtained in the first ovarian stimulation. In this experience, both the first and second stimulations used a classical antagonist protocol with 300 units of FSH per day. Using cetrorelix as the antagonist starting on ovarian stimulation day 6, and the GnRH trigger was done with agonist of GnRH, using triptorelin 0.2 milligrams when the follicular maturation was reached. The first and the second stimulations provided a similar number of oocytes, zygotes, and blastocysts, doubling the final blastocyst yield compared with a classical single ovarian stimulation assisted reproductive technology cycle. What we recommend now is that you can do the first ovarian stimulations using just letrozole or just gonadotropins. It's not necessary to use clomiphene either on the first ovarian stimulation cycle or the second one. And this process should only be recommended to poor ovarian patients or patients in cancer treatments that can postpone their beginning of the chemotherapy or radiotherapy for at least 1 month. And there's another thing, is that we can start at the beginning when the menstrual period comes, the third, the fourth day of treatment of the menstrual cycle, or we can start it the other way, and it's on the luteal phase. We can start the whole protocol as the random start, but we just wait about 48 hours, and then we would start the second ovarian stimulation, and we'll do the oocyte retrieval for almost 14 to 19 days after. The conventional ovarian stimulation, where, well, the theory it's easier than the other protocols, where you just have the timing or you have enough time to do this whole process, would be recommended for non-oncological patients, usually that want to preserve for social or personal conditions or reasons. And then, well, you can wait until the menstrual period comes, and then you would start the whole process on the second or third day of her menstrual period. This protocol is different from the others because you actually don't need the endometrium to grow. So if you don't need the endometrium to grow, in either of the protocols that I already mentioned or this one, you can inhibit the triggering of LH or the peak of LH with progesterone. So instead of using just antagonists, you can also use progesterone. And when the follicles or the measure is above 80 millimeters, you can do the oocyte vitrification, or if she wants, or she has a couple and she wants to, she can do embryo vitrification. And well, why do we all always try to make all the doctors, all the physicians that treat patients to speak about this? And the most important reason, or the thing is that the biggest threat for the fertility is age, is time. And women are increasingly seeking like a timeout until they reach the right moment of their life to have a baby, often postponing childbearing because of the lack of a partner, the lack of a stable partner, or maybe because of her career, financial issues. Maybe she just wants to travel around the world and that's it. But usually the age at which women attempt to have their first pregnancy has steadily rising until the past 40 years. And right now we're seeing that usually women want to have their first child at the age of 35 or above 35 years old. And the thing is that, well, nobody told nature this. And I have here a beautiful chart that shows that the probability of conceptions in patients below 35 years old is really high at the first 12 months. For patients that are at age of 40, these chances or these probabilities of conception diminishes. And at age of 45, the chances are really, really low. So we should recommend all the patients to ask some questions to themselves about if they want to get pregnant or not. And if they do, maybe the ovarian stimulation or the fertility preservation should be for them. Other thing, the risk of having a miscarriage increases with age. And usually at age of 35 years old, from 20 to 35, it's almost the same. But after 35 years old, just the chances of having a miscarriage increases rapidly. And as I usually speak to my patients, it's not just about the numbers, but also about the quality. And I usually use this example as a basket of oranges. When you see a bad orange, you usually don't pick that one up. You usually pick the other ones. And that's exactly what happens with the eggs. At the beginning, you usually choose the best ones. So after 35, you're just not having less numbers, but also the quality of the eggs is less than in other type of patients or younger patients. So this is I hope that a lot of you can use the same example or some similar examples to explain to your patients that it's not just about the number, but also about quality of the eggs. And this problem is not gonna diminish. As I'm showing you here in this graphic, this is the female labor force projections for 2030. And as you can see, almost half of women will be below, one quarter of women will be below 34 years old. And almost 3/4 of women will be above 35 years old, which means that this problem is going to be increasing rapidly with years, because sometimes they look like this. Their couples look like this. Well, they look just healthy, they look younger. You cannot believe that that woman or that man has more than 40 years, but their sperms are just depleting, it's just not good quality, or her ovaries look like this. So the patients will always ask, "Doctor, is it worth it?" And I wanted to bring a chart that it's very good for me also. I really like to explain with graphics to my patients. So here it says that there doesn't exist a magic number of eggs freezing or the success of freezing eggs. But if you have one egg at the age of 30 to 35, the chances of success of pregnancy are around 11%. If you have 5, you have 44%. If you have 10, the chances increases to 69, almost 70%. When you have 20, the chances are around 90%. And when you have more than 40, well, the chances are almost 99%. Well, not almost, 99%. But the thing is that with age, this success rate diminishes. And again, at 37, having one egg just gives her 7% of chances, 5, 29, 10, 50%, 20, 75. At the age of 40, again, the chances diminishes. And above 42, the chances are really, really low. And not only because of the quality, but it's not easy to retrieve 10 eggs from a woman above 42 years old. So it is recommended that if it's possible to freeze eggs, she should freeze eggs early than 35 years old, or at least 37. There's another study from Cobble. That this one is, I think, is the biggest of the reports related to the oocytes and the freezing of oocytes and the results of cumulative live birth rate. And this shows that below 35 years of age, the chances of getting pregnant, or the cumulative live birth rate, are around 90%. When you have 10, it's around 60 to 70%. When you have 5, it's around 20%. But if the patient is above 35 years of age, she's going to have less than 10% having 5 eggs, and less than 40% with 15, and it almost doesn't change after 12 eggs. So when I'm in front of a patient, I usually ask her, "Do you want to be a mother in the future? Or is she determined not to be one? What is her current age? Does her finances allow her to undergo egg preservation treatment? Is there any family history of premature menopause? Or do she has any healthy problems such as polycystic ovary, autoimmune diseases, endometriosis, Turner syndrome, etc., etc.? And that is very important for them, because if any of these questions is yes, well, it would be recommended that she can freeze eggs before it's too late. So in conclusion, improving freezing techniques, ensuring safe outside transportation, well, to provide and extend the access of fertility preservations in large countries and low resources countries like Colombia or things like that, and minimizing the risk of fertility preservation strategies for the patients is one of the most important challenges in the future. And this is like bringing the future to the present. And right now we have very good freezing techniques. That means that we can have at least a 95% of survival rate for eggs and almost 99% for embryos, which means that it should not be a concern for patients. The transportation is another thing, and it's changing with the new politics and the more clinics that have almost the same protocols for freezing and thawing embryos and eggs. Well, you should transport them if you want to have a baby in a different country. For example, you can freeze eggs in Colombia and you can send them to the United States, to Europe, to France, to Spain, to England, even to Australia. And well, the risk of the process of or the risk of the stimulation related to ovarian hyperstimulation syndrome diminishes with the triggering with an analog of GnRH instead of HCG, which means that to recover easier and faster from the whole process. And well, she can start the process in case of oncology patients. She can start the process of chemotherapy 1 week after the whole process. Thank you for your timing and have a good day.
So hello, we are going to talk about the future of genetic screening.
Hello there, colleagues and friends. It's a great pleasure to be sharing time with you again. Thank you. Thank you very much for following us. Today, I will talk about you fertility preservation and reality. So our objectives today is publicize the different indication to preserve fertility, to publicize the prevalence of cancer and survival in women and men of reproductive age, publicize the commitment to fertility caused by different cancer treatments, and publicize the different options to preserve fertility in cancer patients. First of all, fertility preservation is a method of granting people the right to have their own genetic offsprings by preserving germ and gonadal cells. Individuals and couples have the right to decide the number and spacing of their children. Fertility can deny the realization of this essential human right. This is a declaration of the human right. It's important to remember the epidemiology about the ART in USA, Europe, and Latin America. In 2020, USA reported more than 300,000 cycles started, of which more than 22,000 observations. Europe in 2019 was reported more than 357 cycles started, of which more than 45,000 were for preservation of fertility. It means 12%. Now, Latin America in 2019 was reported more than 100,000 cycles started, of which more than 3,900 were by fertility preservation. It means 7.5%. It means that Europe has more cycles of preservation of fertility than Europe and than Latin America. There are some indications about fertility preservation. The first indication is a social indication. It means 73%. Social indication means that the women or men that now that have want to achieve a baby in the future, but not now, and understand that the oocytes in quality and quantity is decreasing with the time is running. So this is the idea to preserve fertility now is better less than 35 years old. So this is a social indication. Is the principal social indication in the world. Another indication is benign pathology. It represents 24%. Oncological pathology is 5.7%, and it's bad because this is an important indication in fertility preservation. But the problem is the instruction that the physician do to the patients. But in some cases, the oncologist and the physician don't explain that this option when the patient is in front of the diagnosis of cancer. And transgender is another indication. In benign pathology, there are some different causes because hematology, so for example, hematologic disease, autoimmune disease, gynecologic disease, and genetic disease. Hematology is the thalassemia, sickle cell disease, Fanconi syndrome, aplastic anemia. In autoimmune disease, SLE, so it's lupus erythematosus systemic, vasculitis, Takayasu arteritis, panarteritis nodosa. Gynecologists, everyday endometriosis is more important because we know that all the patients with endometriosis have a low reserve in the time, and if undergo to the surgery, it's a more low quantity of eggs. Ovarian cysts, borderline tumors, risk of torsion in ovary. In genetic disease, for example, when the patient has relatives with premature ovarian failure, genetic mutation, Turner syndrome, or X-Frail syndrome. And who is candidate to fertility preservation? Any patient who is considering surgery, gonadotoxic therapy, or who wish to preserve fertility in the future. The conventional candidates are patients with cancer or medical condition that require gonadotoxic therapy. Additional candidates are patients undergoing gonadal removal, patients with genetic and metabolic disorders, and carriers of the BRCA gene mutation experience accelerated aging at the ovarian level, but it's better to recommend to preservation of fertility. There are some therapeutic options, for example, oropexin, cryopreservation of embryo, cryopreservation of mature oocytes, and cryopreservation of ovarian tissue. We explain each one. So it's important to remember about the epidemiology more. So in 2012, more than 6 million new cases of cancer in women in the world. 10% are of reproductive age. Between 85 to 90% survive, but with consequence infertility. One of 51 at age of 39 years old, we have a diagnosis of invasive cancer. Between 30 to 50% of young women with cancer will not be offered with fertility preservation counseling. Between 60 to 70% of patients who become infertile after cancer could become mother thanks to treatment offered to preserve fertility. The frequency of cancer in Europe in young people between 15 and 20 years old, the first is Hodgkin lymphoma, testicular cancer, and malignant melanoma. And in patients between 25 and 49 years, is breast cancer, colorectal cancer, cervical cancer, and malignant melanoma. The increase in the number of survivors of different types of cancer is very important to recommend the fertility preservation. Remember, for example, in this case of breast cancer, the incidence in age between 15 and 39, the incidence is 18 per 100,000. And the survival, 5-year survival, is in the 17 was 75%, but in 2000 it's 86%. And for example, you can see all the cancer is same, it's similar. So the 5-year survival in 17 is 73%, but in 2000 is 80%. So it's very important to recommend the patient to go and to do an appointment with the fertility specialist. The reproductive prognosis in this patient depends on the age, the chemotherapeutic agent used, the regimen used, the radiotherapy used, advice on fertility preservation is very important at this point, and availability, accessibility to preservation options. And the first is to explain the age. Remember, the ovary have some stage. Intrauterine, the women have between 6 to 7 million oocytes, but in the natal period is only 1 to 2 million oocytes. And in puberty is 300,000 oocytes. So it's reduced by the time. So in this graphic, we can see the same. You can see 37 years old, and you can see that the quantity of the oocytes is reducing by the time. And what is the average age of women at the time of your first delivery? It's very important to know that in the 70s, between 21, 26 years old was the first delivery. But in the 2000s, it's 4 years more. It's between 25, 29 years old. And now it's worse. The second one is chemotherapeutic agents. We know that there are some agents that is high risk to do an ovarian premature failure, a moderate risk and low risk. The high risk is cyclophosphamide, busulfan, mustasa nitrogenada, melphalan, chlorambucil, and procarbazine. This is very important medicine in the case when you decide to do this medicine. Is very important to do an appointment with the specialist in reproductive medicine. Depend on the regimen used, you have a high risk, an intermediate risk, or low risk. So it's very important to try to match with the age because it's different. For example, in the case that you have less than 30 years old, the probability to do in permanent amenorrhea is less. But if you have more than 4 years old, the probability to have a permanent amenorrhea is higher. In this case, for example, the breast cancer. So the most used regimen is this. If you use it in women that are less than 30 years old, the probability to ovarian failure rate is 19%. But if the women have between 30 and 39 years old, it's until 77%. And if you decide to use taxane, add taxane, the odds rate is 4 times more. So it's very important to understand that the risk of the ovarian failure rate is real. What is the problem with the chemotherapy and radiation therapy? So there are two problems: follicle stage affected and the cell type affected. So the chemotherapy affected directly to the oocyte, the follicles, and directly affect the oocytes and the cell that is around the eggs. In this case, it's granulosa cells and theta cells. The final result is oocyte death. The radiotherapeutic therapy results in ovarian injury and decreases follicular reserve, and the extension is based on age, doses, and radiation path. An additional risk factor is a concomitant exposure to alkaline agents and age at diagnosis. And the effect of radiotherapy in the uterus is a size reduction of the uterus, a reduction of endometrial thickness, and it can adversely affect IVF success. It's very important to know this. But in another risk is increased obstetric and neonatal risk. For example, miscarriage is high, uterine rupture, placenta accreta, gestational loss in second trimester, preterm labor, and low birth weight. In this chart, we can see when the doctor decides to use multi-drug chemotherapy with or without indication depends on the age. For example, age less than 20 years old, the probability to get amenorrhea is between 20 to 50%. The premature ovarian failure is 70%, and the chance of spontaneous pregnancy is 28%. But the women that have more than 25 years is very short. It's amenorrhea between 80 to 90%. Premature ovarian failure is until 100%, sorry. And chance of spontaneous pregnancy is 5%. The problem with the chemotherapeutic agents is that can damage DNA. The chromosomal abnormalities of oocytes is more risk because produce abortion and congenital malformation. The safety of IVF in cryopreservation cancer patients who have chemotherapeutic treatments is questionable. And if you decide to do IVF or you decide to cryopreserve, it's important that the oocyte mortality for 6 months post chemotherapy should be avoided. About a device, the American Society of Clinical Oncology recommends that all oncology healthcare providers should be prepared to discuss infertility as a potential risk of therapy. This discussion should take place as soon as possible once a cancer diagnosis is made and before a treatment plan is formulated. There are benefits for patients in discussing fertility information with providers at every step of the cancer journey. The National Comprehensive Cancer Network Clinical Practice Guideline Oncology in Patient Adolescents and Young Adult Oncology recommend addressing fertility and sexual health in function should be an essential part of the management of adolescents and young adults with carrier who are at risk of impaired fertility of sexual dysfunction due to cancer treatment. Perform an assessment of the risk of gynecologic and impaired fertility due to the cancer. It's a treatment and discuss that assessment and option for fertility preservation with the patient. Do this as soon as possible prior to start of therapy and throughout the course of treatment. The recommendation is discuss the effect of treatment on gonadal hormone function during and after therapy. Some individuals face premature ovarian failure and should be screened and treated by a specialist. Additionally, for the individuals who did not undergo fertility preservation prior to therapy, some may still be eligible for fertility preservation after therapy is completed. After completion of therapy, screen or refer to patient to a specialist as appropriate. For patients who can delay cancer therapy for approximately 3 weeks, discuss oocyte or embryo cryopreservation via immediate controlled ovarian stimulation or random stimulation. I will explain you in the next slide this. For patients who cannot delay therapy for oocyte or embryo cryopreservation, discuss or refer the patient for consideration for ovarian tissue cryopreservation. So this is the recommendation. The ASRM recommends that in patients facing infertility due to chemotherapy or other gonadotoxic therapies, oocyte cryopreservation is recommended with appropriate counseling. The different options of preservation fertility is cryopreservation oocytes, cryopreservation embryos, medical protection with GnRHA, ovarian transposition, cryopreservation transplantation of ovarian tissue, in vitro maturation of immature oocytes, and in men, cryopreservation sperm. The indication of oocyte freezing include post-pubertal patients without a partner or who do not accept bank semen. It doesn't present ethical legal aspect, unlike the possibility in embryo freezing. It says it to be considered experimental since October 2012. The factors to consider is estrogen-dependent tumor. In this case, we need to use letrozole, is an aromatase inhibitor, to try to get less level of estrogen. Possible delay in the start of cancer treatment for us is an emergency state. When the patient calls us about, I have a cancer, the appointment is to do in the same day or the next day in the morning. Available time of the product team and experience of the reproduction team in identification techniques. We have a different stimulation protocols. For example, the classical protocol is this, to start in early follicular phase, but we can start in random way. So I know that we need to gain time because the patient need to start the treatment of the cancer. This is the reason that we can start the process of stimulation in any time. For example, the patients that are in a late follicular phase, we do an ovulation trigger with GnRH, and in the second day, start gonadotropins with antagonists. For example, in the patient that we decide to start in a luteal phase, we start with gonadotropins and GnRH antagonists in the same time. But if the patient have a tumors with estrogen-dependent tumor, we need to start letrozole the first day. So when we do this, we can see that we have a low quantity, low values of estrogens. But this is the reason. So remember, when we use letrozole, the peak serum estradiol at the moment of triggering is 400. But remember, the level in a natural cycle is between 200, 300. But when we don't use letrozole, the level of estradiol is more than 2,200. So we can see a real reduction of the level of estradiol. And it's important to predict results. Predicting results depends the age and the quantity of the eggs. At least 8 to 10 metaphase to oocytes to achieve a reasonable success rate. The numbers shall be individual sizes in women over 30 years old. And pregnancy rate per mature oocyte is 3-5%. So it's very important to show this plot to the patient. For example, the patient who have between 30 to 30 years old, between 35 37 years old, 38 40 years old, between 41 42 years old. For example, if I retire 10 oocytes, the probability to get a baby is 60%, if the woman is between 30 to 34 years. But if the patient is between 35, 37 years old, 10 oocytes is 50% at this one child. But if the patient has between 41 and 42 years old, 10 oocytes is only 20% to have a baby. So it's very important to understand that if the woman has more years old, it's important to get more oocytes. But the problem is to get more oocytes because your ovarian reserve is less than if the woman have less years. You can see in the web a calculator. For example, you can write the age at the freezing eggs, the method of freezing, and how many oocytes stored, and the live birth probability, for example, in this case was 30%. The trends of fertility preservation procedure at EB group is a group of Spain. It's a very important group. You can see that the frozen preservation, the fertility preservation is increased, but is increased because the social frozen preservation is increased. But you can see that the oncological preservation remain low. So it's really bad because this is a special group to try to fertility preservation. The indication of embryo freezing as post-plural patient with a partner or who has a vaccine. So it's very similar to the indication, but the difference is the ethical legal aspect if the patient doesn't survive. But the other factors to consider is the same to oocyte freezing. The live birth rate by embryo transfer in embryo thawing cycles depends on the age. For example, if the woman is less than 35 years old, the probability to have a live birth is 38%. But in the case between 38 and 40 years old, it's 28%. Look at this. And if the woman has more than 42 years old, it's only 15%. The other strategy to try to get a fertility preservation is to use a medical protection for gonads with generation A for fertility preservation in cancer patients. For example, you can see in the chart that the patient that use chemotherapy with tritolin have more cumulative probability of menstrual resumption. If you decide don't use generation A, the cumulative probability of menstrual resumption is lower than when you decide to use, for example, in this case, a tritolin. The ovarian failure is 80% in the group that use generation H. But in the group that only use a chemotherapy, don't use generation A, is 22%. So the already reduced to achieve pregnancy is 2.5 times more. So it's very important to understand esto. So it's very often to see that the oncologists do this using this medicine. When we decide to check anti-mullerian hormone, you can see that if the patient that use anti-mullerian and use generation agonist, the anti-mullerian hormone is higher than the patient that don't use it. So we can conclude that the fertility preservation decision must be taken together with patients, oncologists, and fertility specialists. The possibility of preserving fertility is a part important for the comprehensive management of cancer patients. The strategy should be appropriate, safe, and potentially successful. Proper management of expectation to the careful consultant is very important. All patients should be offered some form of alternative. The prognosis will depend on age, chemotherapeutic agent, regimen used, radiotherapy, advice on fertility preservation, availability and accessibility to preservation options. So thank you very much. Thank you very much for calling us again. And I hope to see you soon. Bye-bye.
Hola, nos encanta que estén aquí. Gracias por aceptar nuestra invitación. Si eres médico, general o ginecólogo, recuerda que para criopreservar tu fertilidad tenemos unos beneficios. Contáctanos a este teléfono y la única condición es que seas mayor de edad.
Hello, everyone. It's a pleasure to be here with you in this lecture. We're going to talk about preservation of fertility in men. I am Jorge Mario Rincón, urologist from INSER Group, Medellin. Male fertility is a complex issue, but there is hope. With early diagnosis and treatment, many men can have healthy children. 50% of the world population has trouble having a children. And infertility is caused in 50% of the cases for factors attributed to men. This could cause consequences in self-esteem, in mental health, and financial status, relationship with his partner, and in general health. And with the study, we have the different objectives. One of these is to know what is the cause of the infertility in those men, and to know if the cause of the fertility problem is reversible or if there is irreversible, and to find out if we need some assisted reproduction techniques like ICSI, or in other cases when there is severe problems, we could use heterologous insemination or adoptions. With the study, we could give to the couple genetic counseling and to know if there is any underlying diseases like cancer or immune disorder that could affect the health of those beings. In cancer patients, there is a lot of fertility problems, and it is known that survival of cancer patients has increased over the time. Cancer per se could affect fertility, and this is caused by multifactorial problems. Treatment of cancer patients could affect fertility too. As you know, many patients could receive chemotherapy or radiotherapy, or they could have severe surgeries that could affect fertility in the future. So, for example, chemotherapy could affect spermatogenesis, producing spermatogonia toxicity, and the effects of these problems could be accumulative. The recovery chance of fertility is between 20 to 80% in some patients. Radiotherapy could affect DNA, and it depends of the dose of the radiotherapy. With low doses, there could be a deterioration of fertility, but with increasing doses of radiotherapy, there could be azoospermia that could be reversible or even irreversible. With higher doses of radiotherapy, there could be a damage of the Leydig cells affecting the testosterone production by the testicles. In this graph, we see with increased doses of radiotherapy, we could damage spermatogonia, spermatocytes, or even spermatides. And this could cause oligospermia, azoospermia that could be reversible or irreversible and could affect the fertility for a long time. So with every physician and every patient, with every physician and every person that treats people with cancer, we must recommend always cryopreservation before any treatment for cancer. That is very, very important in order to preserve fertility in the future. Even in children, we could perform cryobanking, that is to freeze testicular tissue in order to preserve those tissues in the future to get some spermatozoids. to prevent fertility in children. Varicocele is a well-known cause of infertility. The scrotum has to be with a lower temperature compared to the rest of the body. The testicle needs lower temperature in order to produce spermatozoids. And with varicocele, the temperature of the scrotum is increased. So in this systematic review and meta-analysis, they show that early varicocele repair could improve the seminal parameters in most of the people affected with varicocele. Varicocele repair could increase sperm concentration, progressive motility, and normal morphology. So in every patient with varicocele, we must recommend early varicocele repair in order to preserve fertility. Also, with antioxidant therapy, there is some controversy about this eating. But with this systematic review and meta-analysis, they look for a lot of studies, and they found out in 45 randomized controlled trials and more than 4,000 infertile patients that with antioxidant therapy, they could improve seminal parameters, diminishing the free radicals and preserve the DNA integrity. Some medication and drugs that we use for treatment of many diseases could affect fertility too. For example, immunosuppressive medication like sirolimus, cyclosporin, tacrolimus, or mycophenolate could affect fertility. And in those patients, we must recommend cryopreservation before the beginning of the treatment with those medications. With steroids, the literature don't support to stop the medication. With NSAID medication, we don't need to suspend those medications. Otherwise, with opiates, we must suspend the medication because this could affect the motility of the spermatozoids and could affect fertility. Some treatment for prostatic hyperplasia could affect fertility. For example, finasteride could affect the testosterone production inside the prostate and could cause infertility. So we recommend to discontinue finasteride or similar medication for at least 4 months before the beginning of treatment of fertility. With tamsulosin, there is no recommendation at all. Anabolic steroids and testosterone could block the hormonal acts, and this could cause infertility. So we must stop those medications at least 3 to 12 months before fertility. And we must avoid any of these medication when we want to have children in the future. With diuretics, we must discontinue those medications, and the same with antibiotics like nitrofurantoin and sulfas. There are some general recommendations like to have healthy diet. We must recommend to our patients that they must eat nuts, seeds, fruits and vegetables. They must perform exercise at least 3 to 4 times a week in order to prevent obesity and to avoid diabetes, hypertension, metabolic syndrome, and all those diseases. We must recommend to stop alcohol consumption, tobacco use, psychoactive substances and steroids, as we tell before. We must have a healthy weight, sleep at least 7 hours every night, and manage the stress and the anxiety. And in every case, when we have doubt about fertility in the future, we must recommend cryopreservation. In INSER, we are ready to help you in any problem that you have with fertility. It's been a pleasure to be here with you in this lecture. Bye-bye.
encanta que estén aquí, gracias por aceptar nuestra invitación. Si eres médico, general o ginecólogo, recuerda que para criopreservar tu fertilidad tenemos unos beneficios. Contáctanos a este teléfono y la única condición es que seas mayor de edad.
Hola, soy Carolina Cristancho, psicóloga de INSER Bogotá. Gracias por estar en este espacio tan importante de aprendizaje. Hoy vengo con un tema súper especial, aspectos emocionales de la preservación de la fertilidad, un tema que arraiga muchos aspectos importantes en todo el tema emocional a nivel de tratamientos de reproducción asistida. Entonces, quiero presentarles sobre todo el entendimiento sobre qué es la criopreservación y por qué es tan importante a nivel emocional. Entender primero que es un tratamiento de fertilidad que tiene un objetivo específico, que es conservar los gametos. Conservarlos implica un largo tiempo para poder generar un embarazo a futuro y cuando haya una decisión específica deseada. Aquí cada persona, familia, digamos que realiza esa criopreservación de acuerdo a su rol o necesidad, incluyendo en la sociedad. Para entender esto un poco más, hay algo muy importante y es que esto permite ejes de transformación a nivel del individuo. Estamos hablando de que el cuerpo es una entidad sociocultural, por ende cuando las personas conocen un poco más de sí mismas, les permite adentrarse un poco en todo el tema de tratamientos de reproducción asistida. ¿Pero por qué de transformación? Transformación lo que nos implica es que pasemos de los paradigmas que normalmente existen en la sociedad o que una persona tenga la capacidad de romper con ellos para pasar a otros de mucha amplitud y de entender un poco más la ciencia. Entonces, una persona, un individuo, hombre o mujer, que pasa del autodesconocimiento de su cuerpo, puede pasar fácilmente al autoconocimiento. ¿Esto qué quiere decir? Que conocer su cuerpo, su organismo, las capacidades que tiene para generar diferentes aspectos en tratamientos, le va a permitir ampliar un poco más el conocimiento. Un rol como mujer o como madre estipulado en la sociedad es único, pero esto permite también que puedan verlo de múltiples roles o de múltiples maneras, al igual que un hombre. No solo se ejerce un solo rol, sino diferentes roles en la sociedad. Esto permite también que las personas puedan entender que no solo hay un tipo de familia, o que no solo se maneja una familia convencional, sino que pueden haber familias diversas. Esto influye mucho en la monoparentalidad. Una mamá sola por elección o un padre solo por elección. Esto permite también que un tratamiento de reproducción asistida les permita ejercerlo si es la necesidad o si es el gusto de cada persona. Otro aspecto importante es que esto no se convierte solamente en una opción, que normalmente es lo que piensan las mujeres. Tiene que ser por vía natural. Aunque esto implique emocionalmente muchos aspectos, porque siempre el pensado es que una mujer o un hombre va a tener un hijo por vía natural, pues también entrar en el concepto de tratamientos de reproducción asistida y de criopreservación le da otras opciones, tratamientos de reproducción asistida. Y por supuesto el reloj biológico del que tanto se habla, del tiempo en el cual se es o se quiere ser madre o padre, pues cambia también totalmente y lo transforma en que se puede tomar una decisión sobre la maternidad o la paternidad. Permite que yo decida cuándo quiero hacerlo de una forma libre y autónoma. Pero cuando hablamos de preservación de la fertilidad, estamos hablando de que no todas son las mismas implicaciones emocionales, porque lógicamente los motivos por los cuales se preserva o se hace una criopreservación pues son diversos o son distintos. Uno de ellos es el diagnóstico oncológico, que es uno de los más complicados, porque se vuelve simplemente una única opción para poder ejercer un rol materno-paterno, ya que esto implica guardar sus propios gametos. Entonces, esta creo que es una de los diagnósticos más complicados y de más variables que puede tener la preservación de la fertilidad. Otro es el proceso de transición de género o de sexo, que implica demasiada toma decisional y, por supuesto, factores emocionales de evaluar en el tiempo para tomar una buena decisión. La otra creo que implica más emociones positivas y creo que ahí hay un énfasis importante que hacer. Es importante destacar que la preservación de la fertilidad no es negativa, sino que tiene varias opciones o variables. Entonces, las motivaciones personales pueden ser diversas. Una persona, una mujer, un hombre que desea postergar el hecho de ser padre o madre porque quiere encontrar pareja, quiere encontrar una pareja donde vaya a encontrar una estabilidad, que quieran formar un hogar, que quieran ser padres ambos y va a postergarlo el tiempo que sea necesario. Por otro lado, los logros laborales creo que son uno de los que más implica decisiones en las personas. Últimamente encontramos que muchas personas postergan su idea de ser padres porque quieren darle prioridad a sus logros laborales, quieren darle mucha prioridad a alcanzar diferentes metas, y esto permite que la preservación de la fertilidad se vuelva una opción de toma de decisiones libre y autónoma. Pero, ¿qué pasa específicamente en los casos de diagnóstico oncológico o pacientes transgénero? Creo que aquí es donde más importante hay que notar que los cambios emocionales son muy frecuentes. ¿Por qué? Porque las variables como el tiempo, la presión para tomar una decisión son constantes. Por ejemplo, hemos tenido pacientes que llegan, pacientes hombres que llegan a tener que hacer criopreservación de una forma muy rápida, porque inician posteriormente una quimioterapia. Entonces, su médico tratante les dice, miren, hay una opción para que ustedes puedan criopreservar, para que puedan preservar su fertilidad, pero tiene que ser ya. Entonces, ese tiempo se convierte en una presión para ellos, en los que no tienen como un buen procesamiento emocional que les pueda permitir tomar la mejor decisión, sino que es una decisión impulsada, obviamente, por un diagnóstico y porque adicional empiezan de una forma inmediata un tratamiento. Entonces, aquí revisamos que obviamente hay mucha combinación emocional. Entonces, emociones que pueden implicar tristeza, frustración, rabia, fracaso, obviamente, combinadas con esas emociones de incertidumbre de lo que puede desencadenar el futuro incierto de soy madre o soy padre. Estudios han revelado en este aspecto algo muy importante para los pacientes que logran preservar su fertilidad. Entonces, estudios como cuáles. En el 2005 se realizó uno específico, Saico y sus colaboradores decían y concluían que las personas que pueden preservar su fertilidad son mucho más propensas a que durante el tratamiento oncológico, bien sea la quimioterapia, radioterapia, entre otras, puedan estar mucho más estables debido a que pueden guardar su fertilidad o preservar su fertilidad de una manera posterior, aunque obviamente esto implique que haya una incertidumbre constante en si lo van a lograr o no lo van a lograr. Y por supuesto, pues en los temas de transición se van a generar muchos conflictos de identidad. Creo que esto es uno de los tópicos en los que más precisión y de acompañamiento emocional se necesita para poder tomar una decisión adecuada que permita no tener más allá de esos conflictos y poder ejercer su preservación de la fertilidad como se quiere. Pero cuando hablamos tanto de estas implicaciones emocionales, podemos preguntarnos qué desafíos hay. Los desafíos son durante todo el proceso, pero creo que es importante hacer hincapié cada paso a paso que tiene el antes, el durante y el después de la criopreservación. ¿Qué hay en la mente de cada una de estas personas que toma la decisión, sea por la circunstancia que sea? ¿Cómo la desencadena? ¿Cómo la puede manejar? Y obviamente lo más importante aún es cuál es el acompañamiento adecuado para cada uno de estos momentos. Si miramos una cadena del tiempo, siempre está regida por un aspecto emocional súper importante y es la ansiedad. Antes de iniciar un tratamiento, siempre hay diferentes preguntas que tienden a ser demasiado anticipatorias. Y es porque las expectativas de cualquier tipo de tratamiento de reproducción asistida, y en este caso para preservar la fertilidad, pues obviamente se tiende a pensar que es supremamente sobrevalorada. Entonces, la expectativa es muy alta. La expectativa es que todo tiene que salir de una forma perfecta, independientemente del desconocimiento que haya a través del proceso. Pero aquí las preguntas constantes y se ven en consulta constantemente es realmente cómo funciona ese tratamiento. ¿Funciona o no funciona? ¿Cómo puede afectar física, hormonal y emocionalmente este tratamiento? Entonces, obviamente todas las pacientes desde su foco de atención respecto a lo que viene van a tener diferentes preguntas que van a implicar un aumento constante en su ansiedad o en su estrés. Y esas dudas constantes sobre el futuro y anticipación constante también refiere preguntas como, ¿será que sí voy a utilizar estos óvulos? ¿Será que este esfuerzo físico, económico, emocional, hormonal va a valer la pena? ¿Quién me garantiza que sí vaya a poder yo tener un hijo con esto que estoy haciendo? Y si no lo logro, ¿será que me voy a arrepentir de la decisión? Entonces son constantes preguntas que lo que se quiere hacer a través del acompañamiento emocional es reducir las preguntas a través de diferentes herramientas que puedan ser óptimas para tomar una buena decisión respecto al tratamiento que se puede manejar. El durante es otro aspecto importante de mencionar, pero donde siempre va a estar implicada la emoción de la ansiedad. ¿Por qué? Pues por el paso a paso del tratamiento, por la información que se obtiene. Creo que en cualquier tipo de tratamiento de reproducción asistida siempre están muy presentes las redes sociales, siempre está muy presente la información o el desconocimiento, y esto implica que todas las preguntas asociadas a saber si este tratamiento me va a servir o no están relacionadas con el aumento constante de ansiedad. La ansiedad es un temor, es un miedo al futuro, un miedo anticipatorio, un miedo que avisa qué riesgos, qué efectos secundarios puedo tener durante la estimulación y captación. De ahí la importancia de que el médico tratante pueda tener esa capacidad de informar adecuadamente, de hacer ver cuáles son esos riesgos, qué puede pasar. Cuando se le brinda toda esa información, la paciente de cierta manera o los pacientes van a estar un poco informados, y el tener información los hace sentir seguros, y el sentirse seguros los hace sentir confianza en dónde, en el lugar en que lo están haciendo, y por supuesto de los resultados del tratamiento, independientemente que no sean tan positivos como obviamente se espera. Y el después es otro reto que hace parte de cuál es la elección que yo tomé, que me implica a futuro esta decisión de preservar mi fertilidad. Entonces, es una decisión de obligatoriamente voy a tener que someterme a un tratamiento de alta complejidad por mi decisión, por la decisión que tomé unos años antes, porque yo lo quise hacer, porque si es en el caso de las motivaciones personales, es una decisión de elección, y por ende va asociada a entender que voy a tener que tomar un tratamiento de alta complejidad. Y por supuesto toda la esperanza del éxito, que haya mayor esperanza de éxito ante haber guardado, haber preservado mi fertilidad con tanta anticipación. Pero resulta que a veces cuando no es el impacto o el resultado que se obtiene, pues el impacto va a ser totalmente diferente. Si obtengo una beta negativa, ya hablándolo ya a un futuro más lejano, pues lógicamente el impacto de no entender qué fue lo que pasó va a generar un aumento constante del estrés o la ansiedad en la persona. Y por eso, pues nos basamos tanto en dar mucha repetición en por qué es importante el acompañamiento emocional y de qué forma se debe hacer, o de qué forma buscar las mejores herramientas desde el antes hasta el después. Y es entender el modelo de atención integral que se debe mantener constantemente. Es un modelo de atención de acompañamiento, de aumento de herramientas, de aumento de estrategias de acuerdo a la persona, de acuerdo a la situación, de acuerdo a la circunstancia por la cual se hizo una preservación de la fertilidad. No obstante, pues sí es importante aclarar que aunque todos necesitan ese acompañamiento, sí hay que hacer mucha precisión, sobre todo en las decisiones cuando son por alguna enfermedad o por alguna característica o diagnóstico que implica esa decisión obligada. Entonces, el antes yo creo que es lo que se mencionaba anteriormente, cómo podemos llegar a ajustar las expectativas presentes y futuras de un paciente, qué herramientas se le puede brindar a nivel psicológico para poder generarlo. Creo que una reestructuración cognitiva constante de mantener los pensamientos sobre la realidad va a ser muy importante. Acompañar en la toma de decisiones, la decisión que se está tomando, el motivo, la circunstancia por la cual se está tomando esa decisión es trascendental para que la persona vea todas las variables, las analice, las lleve ella misma o él mismo a un concepto para poder tomar la mejor decisión acompañada y, por supuesto, pues llevada de herramientas que le permiten dar una buena regulación emocional. Esto también es importante porque el análisis emocional constante en las posibles complicaciones va a generar una apertura en el pensamiento de las personas. Entender qué es lo que viene, entender qué puede pasar, entender que no todo puede ser de una forma perfecta, pero eso implica un trabajo emocional y un trabajo de mucho análisis que implique que esa persona entienda a qué es lo que se está sometiendo. Y por supuesto esa elaboración de la incertidumbre, la reducción de las preguntas, la reducción de la anticipación constante, herramientas que se puedan brindar a través de diferentes aspectos va a permitir que esta persona entienda también cómo funciona su mente, cómo funcionan sus emociones para poder llevar a cabo ya la toma de decisiones final. Ahora, el ese durante, creo que también es indispensable tener varias herramientas que permitan la preparación para el tratamiento. Entonces se viene una estimulación, va a haber un contenido hormonal muy alto, donde pueden variar emociones abruptamente. Entonces creo que aquí aspectos que tengan que ver con la regulación emocional hay que aplicarlos constantemente. Como que creo que aquí principalmente lo que derivamos en ese manejo de ansiedad es que haya mucha respiración diafragmática, ejercicios de respiración diafragmática, que haya distracción cognitiva, que puedan haber diferentes actividades que permitan que esta persona pueda mantenerse dentro de sus posibilidades lo más tranquila posible para afrontar cuál sea el resultado, pero sobre todo el momento de la captación y lo posterior que viene acompañado de diferentes sintomatologías. Y ese acompañamiento hace parte de esas complicaciones médicas, de aspectos que no se esperan, de aspectos que pueden estar evidenciados cuando termina cada uno de los procesos. Ya cuando hablamos del después, pues lo hablamos respecto a un futuro más a largo plazo, pero sigue siendo parte de este modelo de atención integral porque eso prepara para un futuro respecto a cómo va a ser el tratamiento de cada persona. Entonces, si posterior a ver una criopreservación, viene un tratamiento de alta complejidad y se encuentra una beta negativa, ¿cómo hacemos para intervenir? ¿Cómo hacemos para reducir la carga emocional? ¿Cómo hacemos o generamos una validación emocional de esta situación? Y por supuesto, lo que contiene es la preparación emocional para un nuevo ciclo, si es que lo va a haber. Porque creo que uno de los aspectos es tener en cuenta cuál puede ser el cierre de ciclo de cada persona si es que no se decide hacer una continuidad del proceso. Entonces, en el sentido de cómo acompañar, siempre es importante revisar cuántas herramientas o qué herramientas y estrategias pueden estar presentes en cada uno de los pacientes de acuerdo a su situación, su forma de ser, pensar y revisar diferentes aspectos en el tratamiento pueden ser oportunos y manejables en cada situación. Toda la repetición del acompañamiento psicológico hace una conclusión especial. Siempre deben haber herramientas de regulación emocional, herramientas que permitan que durante todas las etapas del tratamiento la persona pueda sentirse uno acompañada y dos, manejar todas las situaciones que están presentes o inmersas durante todo el tratamiento. Y no olvidarnos que aunque parezca que todo produce mucha carga emocional, tristeza, rabia, frustración, entre otras, también hay emociones positivas que pueden acompañar un proceso posterior a futuro que sale con una beta positiva exitosa, pues va a generar emociones positivas. Lógicamente, las motivaciones personales a las que cada una de las personas en toma de decisiones genera para hacer una criopreservación, pues también genera emociones positivas. Por ende, siempre hacer como el análisis respecto a qué es negativo y qué es positivo en estos procesos se genera también para poder brindar las herramientas adecuadas a cada caso y a cada proceso, bien sea exitoso o no. Y pues lógicamente porque al tomar decisiones respecto a criopreservar, respecto a las motivaciones personales, pues cuando hay libertad es autónomo y es una decisión sensata que quizás cada persona quiere tomar, pues va a permitir que los procesos sean muchísimo más equilibrados emocionalmente. Gracias por habernos acompañado. Espero poder encontrarme con ustedes en una próxima.
Hello, we are going to talk about the future of genetic screening for premature ovarian failure, or POF. From this moment, we will refer mainly about POF. My name is Carlos Trujillo. I am a medical geneticist and working at INSER. Premature ovarian failure has been defined as menopause before the age of 40, with elevated LH and FSH and low levels of estrogens. The age of menopause is an inheritable trait and is considered now to be a polygenic, meaning that there are many genes that act together to produce this phenotype. The heritability of menopause from mother to daughter pairs range in different studies from 44 to 65%. The identification of the genetic causes of in POF is useful not only for the patient, but for the close female relatives, because cryopreservation of eggs or ovarian tissue or embryos is a possibility that we should take advantage of. The genetic causes of POF are diverse. We have karyotypic or chromosomal abnormalities, single gene defects, no coding RNAs, mitochondrial gene defects, and polygenic causes. Among the single gene defects, there are some autosomal defects that are syndromic, like galactosemia, and others. Isolated disease, non-syndromic, like, for example, FSH or LH resistant due to mutations in the receptor. Immune function genes, like interleukin 11. Some DNA repair genes variants, like, for example, the one associated with microsatellite instability, MSH4, MSH5, and some of the Fanconi anemia genes that are also associated with some cancers, like breast cancer and ovarian cancer. Premature aging syndromes, like Bloom syndrome and Werner syndrome, and pseudo Werner syndrome due to MDM2 mutation that we recently reported in 2017, a dysfunction of this MDM2, which controls normally the P53, which is a tumor suppression gene, and usually in cancer is decreased. In this patient with premature aging is overactive and is producing the aging. And also in the females affected with this syndrome, there is a premature ovarian failure and usually menopause before the age of 18. X chromosome defects, abnormalities are cause of more than 12% of the cases of POF, are either whole or partial deletion, duplication, or translocation of the X chromosome. The most common ones are the X monosomy, 45X, or Turner syndrome, which has an incidence of 1 in 2,500 births, female births, and is associated with short stature, gonadal dysgenesis, and primary amenorrhea. Trisomy X, or 47XXX, is more common, occurs in 1,000 females. Usually the phenotype of these females is normal, and very often is present as a mosaic with other cell lines like 45X, quadruple X, 48XXXX, or a normal cell line as a mosaic with the triple X. They are easily detected by the regular karyotype or by FISH. In the chromosome X, we have in the long arm of the chromosome X, there is two regions called POF1 and POF2, which are critical regions, and they are associated with abnormal structural variants of the X chromosome that causes POF. No single gene has been found in this region, but genes for normal ovarian function for sure are in this area. Here we see a balanced translocation between the long arm of chromosome 9 and the long arm of chromosome X that cause POF. Also duplication in the long arm of the chromosome X or deletions in the long arm of the chromosome X are causes of POF. The most common single gene defect associated with POF is the Fragile X associated primary ovarian failure. Usually the patients have a pre-mutation that is carried in 1 in 250 women. The normal gene, the FMR1, has 45 repetitions, less than 45 repetitions of a triplet, this cytosine, guanine, and guanine. And when there is a pre-mutation, this repetition is amplified from 55 to 200 times, and it's increased the risk of POF. And the highest risk is when this amplification is between 80 and 100. Above 100, the risk is also high, but not as high as in this range. FMR1 permutation is the main heritable cause of sporadic and familial POF. 20% of the women who carry a Fragile X permutation develop POF, compared with only 1% of the population. But if the permutation is from 80 to 100, the risk is 40%. 1% of the women will have menopause before the age of 18 when they carry a permutation. Age of the menopause is 5 years younger than the average of the general population in these permutation affected persons. When there is a permutation, the risk of a full mutation of more than 200 repeats in the next generation increases according to the number of repeats in the permutation. When the permutation is above 100, the risk is close to 100 to have in the next generation the full mutation, which would present with the full-blown syndrome as the Fragile X syndrome that is associated with sometimes with severe mental retardation or intellectual disability. Recently, studies of the whole exome from the more than 135,000 patients from the UK Biobank found rare variants in genes associated with menopause. In these 3 genes, they found association with early menopause, and in these 4 genes, association with later menopause. The CHEK2 gene is a tumor suppressor gene, which has been associated also with uterine fibroids, polycystic ovarian syndrome, prostatic hypertrophy, and breast cancer risk. Usually, the normal CHEK2 destroy the eggs when they have damage of the DNA. But when it's lacking the CHEK2, these patients have a delay in the menopause of more than 3 years. And they respond strongly to the ovulation of IVF. There is another gene similar to this that is called CHEK1 that also is considered to be a tumor suppressor gene, but no homozygous loss of function in human tumor has been detected yet. When there is a CHEK1 inactivation, this is associated with infertility, but when there are extra normal copies of the CHEK1, it's also associated with longer reproductive potential and later menopause. Also, a recent study published in Nature Medicine in July 2023 evaluate most of the genes causal homologenic disorders or POF using exomes from more than 200,000 patients from the UK Biobank. Half of these genes are autosomal dominant, and they found in this study that they are either partially penetrant or no pathogenic at all. Curiously, these genes are used in panels that are commercially available, and of course, after this study, it doesn't make any sense to use these panels anymore. So, in conclusion, in this study, they found that most of the cases are probably due to multifactorial or polygenic reasons. Almost all traits and common disease are multifactorial or polygenic. The difference between multifactorial and polygenic is that the polygenic plus some kind of environmental trigger produce is what is called multifactorial. The genetic diseases are usually classified as monogenic or polygenic. Monogenic are due to a single variant or a single mutation that produce the disease. Like typical examples of this, we have the cystic fibrosis, the hemophilia, and Duchenne muscular dystrophy. But most of the diseases of the adult and the children are due to polygenic reasons. Like, for example, in ischemic heart disease, and there are many variants that sometimes are more than 100 of variants or mutations that produce the disease. These variants, when they are due to only a change of one nucleotide, we call them SNPs, or single nucleotide polymorphism. When we do a whole genome sequencing of a person, we find more than 5 million of these SNPs or variants. But in the whole population, these variants are present in more than 100 million variants or SNPs. When we filter and we select only the variants that are inside of the genes, we can reduce this number of variants to around 22,000. And if these 22,000, probably there will be only hundreds of them who are really deleterious, and few of them will be casual variants or monogenic diseases. And these variants have been associated with different phenotypes, different diseases, and for example, with poor ovarian response, we have found variants or SNPs in the FSH and LH and estrogen receptors, and they are diagnostic markers of poor ovarian response. Also in the anti-Mullerian hormone AMH receptor, there are SNPs that they are increase the risk of diminishing ovarian response. Also SNPs in the p53 tumor suppression gene have been shown to have an impact in the results of the IVF. The polygenic model has been described in genetics for more than a century, it was described by Ronald Fisher, and it states that a trait is influenced by infinite number of SNPs. At that moment he called it genes. So as we see here, as the number of SNPs or genes increase, there is a moment that there is a threshold where the phenotype of the disease is clearly manifest. Also, environmental factors may trigger this disease or this trait, and also reduce the number of SNPs that then is needed to produce the disease by displacing the threshold to the left. But there are so many continuous traits where there is no threshold. For example, in the skin color, there is a gradual number of SNPs that increase and is associated with the color of the skin. And this also is valid for the blood pressure, for the height, for the intelligence, and for the age of the menopause. The association of SNPs with diseases has been found through case and control studies called GWAS studies, which have been developed mainly in the last 20 years. Basically, a GWAS is a case and control study where we have hundreds of thousands of patients, and we have also thousands or millions of persons who are controls. And in each one of those, we evaluate a series of SNPs, which could be from around 500,000 to more than 5 million SNPs. Here we see, in this graphic, we see only 3 SNPs. The first one and the second one there is no difference between the cases and the controls, but in the third one, we clearly see that the SNP number 3 is associated with the disease compared to the controls. 3 factors enabled the development of GWAS during the last 20 years. One was the establishment of biobanks like the UK Biobank, which has a collection of more than 500,000 persons, which have been clearly, carefully phenotyped and also genotyped, and there is sequence of many, whole genome sequence of many of these patients and exomes. The second one is the HAPMap project, which was started in 2003 after the completion of the Human Genome Project. and it lasted for 3 years until 2006. In this HAP-MAP project, there was a catalog of SNPs in different populations from all over the world, and is enormously useful for these studies of GWAS, and extremely important. And the third one is the technological advances that develop the microarrays that now allow to study millions of SNPs in a single patient at the time, with prices that are very accessible now for these studies. From GWAS, we develop a way to score the SNPs that is called polygenic risk scores, or PRS. A PRS is a number that summarizes the effect of the genetic variants on an individual's risk of developing a disease. Each SNP is given a weight and according to its association with the disease. The addition of these weights gives the PRS, or the final number. The higher the PRS, the higher the risk of the disease. Here we see in a big study of thousands of patients with cardiovascular disease, where they evaluated more than 6 million of SNPs. They found that more than 95 SNPs of gene regions were associated with the myocardial infarction. And they developed a prediction using PRS and using machine learning and artificial intelligence. This PRS is now used in clinics all over the US, in cardiology clinics, and is an independent risk factor, independent of the values of cholesterol, triglycerides, independent of the family history, independent of the smoking history, and is even stronger than all these risk factors. But also for other diseases like atrial fibrillation, diabetes type 2, and breast cancer, there has been PRS that are now starting to be in use. For example, for breast cancer prediction, and in 95% of the breast cancers who are no inherited, we call it sporadic or multifactorial or polygenic, and we can stratify the risk according if the patient has a low risk, maybe there is no need for screening, or the mammography can be done, every 3 or 4 or 5 years. But if the patient has a high risk, the screening by mammography should start at 30 years of age, and maybe also MRI should be used in the screening of these patients. Because if a patient has a PRS above the 90th percentile, the probability of developing breast cancer is about 33%. And if the patient PRS is above the 95th percentile, there is a more than 50% probability of developing breast cancer. And this is equal or similar to some of the heritable breast and ovarian cancers like BRCA1, BRCA2, PALB2, CHEK2, ATM, RAD51, and others. In the field of the age of menopause, also there has been several GWAS done in the last 15 years. The first one reported in 2012. They evaluated less than 20,000 patients, and they found 13 regions associated with or 13 SNPs associated with the age of menopause. Later, in around 2020, there was another study with close to 50,000 patients, where they found 49 regions. And the latest is a big study done with the exomes of the UK Biobank, more than 200,000 samples. They found 290 regions or SNPs associated with the age of menopause. So in this study, in the last study was mentioned, it was possible, for example, to detect the high risk in the top 1% or above the 99th percentile of the PRS score. The patient have an increased risk or 5 times above the general population, and this is the risk similar or equivalent to a patient who have FMR1 gene premutation. So, in conclusion, genetic variation could help predict timing of the menopause. Very soon, all these tests will be available to make these predictions, and it will be help in planning ahead, preserving oocytes, ovarian tissue, or embryos, not just for the patient, but also for the close relatives who can be evaluated using this PRS. It will be possible also in the near future to extend fertility by use of CRISPR and gene editing. And these technologies are now applicable in other fields, like, for example, in hematology, there are many cases of correction now of sickle cell anemia using these technologies, and for sure will be available in other specialties. Thank you very much.
Hola a todos, espero que tengan un buen día. Hoy mi nombre es Juan Gabriel Martínez Lugo, estoy en la sede de Cartagena y Barranquilla. Hoy le voy a hablar de un tema muy interesante. Le voy a hablar sobre consideraciones legales sobre la preservación de la fertilidad. Es un tema que creo que nos compete a todas nuestras pacientes que son jóvenes, que están pensando en esto de preservar la fertilidad, sus óvulos, en que el tiempo va pasando y que de cierta manera es importante tener un plan B por si acaso las cosas no se dan a futuro con respecto a la búsqueda de bebés. Y quiero que hablemos un poco de cómo se está manejando a nivel mundial todo este tema de la preservación de fertilidad. Obviamente nosotros siempre lo miramos desde nuestro punto de vista acá en Colombia y lo que hacemos todos los días, pero es importante saber cómo se está comportando el mundo con respecto a este tema en Europa, en Estados Unidos, en nuestros países hermanos, con respecto a las mujeres que están deseando también preservar la fertilidad. Entonces, un momento, por favor. Digamos que a nivel de políticas internacionales, en general, con respecto a técnicas de reproducción asistidas, en 1994, en la cuarta conferencia internacional en el Cairo, marcó un cambio de políticas con respecto a lo que tradicionalmente se venía antes de esta época o antes de este año, de que había que tener un concepto de planificación familiar a nivel global, para centrarse en este momento, más que todo en los derechos sociales y reproductivos de las personas. Se comenzó a hablar desde ese momento en que había que cambiar un poco el chip y no solamente hablar de planificación familiar. Se reunieron 179 países en ese momento, incluso Costa Rica, que tiene algunas, digamos, restricciones con respecto a fertilidad, ya lo hablaremos ahorita en la conferencia, y más de 1.200 ONG para hablar de salud sexual y reproductiva, y se hicieron unas consideraciones con respecto a promoción de salud, derechos reproductivos y acceso universal de estos servicios a nivel general. Un año después de 1994, y se hizo una validación con respecto a la conferencia o a esta conferencia internacional. En el 2000, en la Asamblea General de Naciones Unidas, se adoptó la Declaración del Milenio y los Objetivos del Milenio. Sin embargo, en esta asamblea muy importante no se habló tanto de la salud sexual y reproductiva, no fue incluida como un tema prioritario, pero sí en los diferentes objetivos que tenía, digamos, de resolución de esta asamblea como tal. En la cumbre mundial de 2005, los gobiernos corrigieron hasta cierto punto esta omisión, ¿sí? Hablando de políticas internacionales en general con respecto a técnicas de reproducción asistida y a pensar en salud sexual y reproductiva. Entonces, digamos que a nivel global, con respecto a técnicas de reproducción asistidas, hablando de todas las técnicas, obviamente, no solamente de criopreservación de óvulos, hay un comportamiento diferente dependiendo de los países. Por ejemplo, vemos en Japón, Australia, en Suecia, en los países, en Francia, en Europa, en general y Estados Unidos, que se hacen mucho más ciclos. Por ejemplo, en Japón se hacen 3.545 ciclos de técnica de reproducción asistida en general por millón de habitantes. Mucho más, la población tiene mucho más acceso. En cambio, si lo miramos en nuestros países, en Latinoamérica, y vemos, por ejemplo, el caso de Argentina y Uruguay, que por ley tienen algunas técnicas, están incluso se lo cubre la ley, tienen acceso, digamos, las aseguradoras le dan acceso a nivel gratuito a las pacientes, hacen 500 ciclos aproximadamente, 535, en este registro que fue del maestro Seger, registrado en la red LARA, 535 ciclos por millón de habitantes. Y en el caso de países nuestros, lo vamos a ver ahorita en Colombia, pero en Latinoamérica no es tan frecuente como lo quisiera. Israel, en el caso de Israel, es el país con mayor utilización y creo que es uno de los que da mayores beneficios con técnicas de reproducción asistida. Está haciendo 5.500 ciclos para este registro de 2017 por millón de habitantes. Y su legislación contempla un acceso muy importante para la proyección de completar la familia para muchas parejas. Y obviamente ya en otra gráfica más adelante hablaremos de cómo se comporta Israel con respecto a la criopreservación de óvulos. En Latinoamérica, lo que es Argentina y Uruguay son dos países, como habíamos hablado, como estaba explicando ahorita, con leyes que han dado cobertura, en teoría universal, de las técnicas de reproducción asistida. Han avanzado de forma muy importante y obviamente eso hace que a nivel de Latinoamérica hagan mucho más ciclos que otros países como nosotros. La recomendación en general es que si lo comparamos con países europeos, por ejemplo, o de Asia o Oceanía, que hagan 1.500 a 3.000 ciclos por millón de habitantes. Y digamos que aún teniendo cobertura, Uruguay y Argentina están haciendo entre 500 y 400 ciclos por millón de habitantes. En nuestro país, en Colombia, por ejemplo, tenemos 143, 150 ciclos de in vitro por millón de habitantes por año. Y esto es el registro también de la red Lara en el 2019. La recomendación en teoría para tener un acceso o una utilización de las técnicas de reproducción asistida en general a nivel global es que, digamos que haya un acceso asequible en la población que tenga más o menos de 1.500 a 2.000 ciclos de técnica de reproducción asistida por millón de habitantes. Y bueno, yo creo que nos falta bastante a nivel de Latinoamérica para cumplir todo esto. La mayoría de países en América Latina no tienen una regulación clara con técnica de reproducción asistida. Por ejemplo, en Brasil solo hay una resolución que la da el Consejo Federal de Medicina y es la Ley 69. En México y Brasil también, digamos que cubren las técnicas de reproducción asistida. El Estado no las cubre, pero están permitidas solamente para matrimonios estables. Se permite criopreservación de óvulos, donación, digamos, está permitida como está por la ley. En Costa Rica ha tenido algunos inconvenientes, incluso tiene algunos inconvenientes legales con este asunto, porque en el año 2000 el país prohibió técnicas como la fertilización in vitro y también inseminación con donantes. Solamente se permite inseminación homóloga. Creo que de todos los países de Latinoamérica es que tiene un retroceso mayor con respecto a técnicas de reproducción asistida en general, ¿no? En general. En Colombia, ya para hablar un poco de los países, específicamente nuestro país, en Colombia la ley 593 de 2019 estableció unos lineamientos para el desarrollo de política pública de prevención de la fertilidad y su tratamiento dentro de los parámetros de salud reproductiva en Colombia. Sin embargo, esta ley, que fue una ley ambiciosa, en la cual quería incluir las técnicas de reproducción asistida, que las cubrieran las aseguradoras o el Estado como tal, especialmente para la población que no tenía recursos económicos para hacer ciclos y tratamientos de reproducción asistida en general, quedó congelada, especialmente por el tema de la pandemia, e incluso no solamente por la pandemia, sino también porque el ministerio en Colombia vio que para poder hacer este tipo de técnica en la población a nivel general, había que hacer un sobreesfuerzo fiscal y seguramente dejaba de cubrir algunas necesidades de diferentes servicios de salud si hacían un acceso universal. Incluso hubo reuniones en el ministerio y se hablaron de hacer 3 ciclos de tratamiento hablando de fertilización in vitro, pero hasta la fecha actual esa ley, digamos, no ha tenido avances y no hay cobertura, digamos, gratuita o por el Estado o aseguradoras que cubran las técnicas de reproducción asistida. Usualmente todo lo que se hace actualmente, aunque sí hay legislación de las técnicas como tal, el costo como tal lo debe cubrir la paciente. Algunas veces la Corte Constitucional, en algunas pacientes que hacen tutela o no tienen los recursos económicos o tienen enfermedades complejas, le ha permitido hacer algunos tratamientos de fertilidad, especialmente por la política que tenemos sobre la sexualidad y derechos reproductivos. Uruguay, creo que fue después de Argentina, pero Uruguay tiene esta ley, que es la ley 19.167, y tiene estos 2 artículos importantes en el cual, ya hablando de la criopreservación como tal, incluyó la criopreservación, pero ellos lo incluyeron solamente en el paciente oncológico, únicamente. No por ejemplo, la paciente que tenía endometriosis o que por edad deseaba vitrificar o congelar los óvulos. Solamente en paciente oncológico, estamos hablando de, por ejemplo, pacientes con cáncer de mama, previo a la quimioterapia, podían acceder de forma cubierta por el Estado o por aseguradoras sin pagos por, digamos, la técnica de criopreservación como tal. Y dieron un rango de edad, podía hacerlo pospubertad y máximo hasta los 40 años. Y en este caso, si iba a tomar la técnica de criopreservación, el médico tratante tenía que dar su consentimiento como tal, y además de eso, un aval de la dirección técnica del prestador que le iba a prestar el servicio como tal. Entonces, de cierta manera, sí está cubierto, pero solamente en esta condición. En el artículo 3, en Uruguay, el Estado garantiza las técnicas de reproducción asistida, digamos que están inmersas, pero más que todo, técnicas como fertilización in vitro o IPSI, hay más proliferación o está más cubierto que la criopreservación como tal. Hasta ahora solamente en pacientes oncológicos. En Argentina tienen la ley 2686-271 y un decreto que lo reglamentó, que es la 956 de 2013, que sin duda es un avance legislativo importante para ellos, porque vino a resolver algunos vacíos legales que tenían. En Argentina, digamos que comenzaron a haber una cobertura de las técnicas de reproducción asistida a nivel universal, sin tener incluso límites de los ciclos de in vitro. Posteriormente cambiaron esto, y hablando de ciclos de in vitro como tal, solamente actualmente permiten hacer 3 ciclos, ya sea que lo cubra la medicina prepaga, como le llaman ellos, o la obra social, o el Estado como tal. Con respecto a la preservación de fertilidad, la ley no establece beneficio en el caso de vitrificación de óvulos por causas sociales, es decir, por una paciente que tenga una edad reproductiva y esté preocupada por el paso de los años, no le cubre, y tampoco la que tenga de pronto endometriosis, ¿sí? Entonces, de cierta manera, a pesar de que sí cubre otras técnicas como la fertilización in vitro, para proceder o para poder hacer una criopreservación de óvulos, lo tienen que hacer de forma privada. O sea, le toca pagar al paciente en este caso, ¿no? En Chile, el Estado, digamos, contribuye a las técnicas de reproducción asistida. No hay una ley, digamos, establecida que cubra y que pague como tal los costos para los pacientes que tengan la necesidad en general de técnica de reproducción asistida, pero hay un Fondo Nacional de Salud que se llama FONASA, que es un mecanismo que cubre más o menos 300 o 400 ciclos anuales en pacientes que de cierta manera, hablando de técnica de reproducción asistida en general, no pueden de cierta manera costear este tipo de técnicas. No está incluida la donación ni los costos de criopreservación embrionaria en este fondo como tal. Y en el 2019, además de eso, existe una serie de modalidades que se llama de libre elección de FONASA, en el cual hay como un copago para algunas pacientes que de pronto, de cierta manera, no puedan, tampoco puedan pagar, el Estado o el fondo paga algo, y el paciente tiene que pagar como un porcentaje con respecto al costo como tal, y solamente puede hacer 2 intentos de por vida, o sea, solamente le permiten hacer 2. Y son, como le decía, 300 a 400 ciclos anuales, no es para todas las pacientes, ¿cierto? Y hablando en general de técnica de reproducción asistida, no para vitrificación de óvulos. En Estados Unidos cambia un poquito la circunstancia, ¿cierto? Entonces, digamos que en Estados Unidos hay 7.000 personas aproximadamente con un diagnóstico de cáncer que va entre las primeras edades de su vida hasta los 39 años anualmente. Y estas pacientes tienen, digamos, por las nuevas formas de manejo del cáncer, muchas veces mucha posibilidad de superar la condición, y en algunas pacientes tienen un alto riesgo de infertilidad, especialmente por la quimioterapia y radioterapia, y esto obviamente es para todos los países o todas las pacientes del mundo que se le haga quimioterapia o radioterapia y necesiten criopreservación. Sin embargo, los costos elevados de la criopreservación puede ser para los pacientes en Estados Unidos de cierta forma inaccesible. Oscila aproximadamente entre $5.000 y $10.000 aproximadamente el costo de tratamientos de criopreservación. Y si bien hay una ley, y en el 2017 a 2021 se incluyeron 11 estados a este tipo de norma, que son los que tenemos acá: California, Colorado, Illinois, ¿sí? New Jersey, New York, Utah. Ellos no cubren de cierta manera el Estado los gastos de técnica de reproducción asistida y de criopreservación. lo que hicieron fue una orden judicial en el cual las aseguradoras como tal, o sea, es decir, el paciente tiene que tener una cobertura por seguros, que el cual paga, le puede prestar los servicios. Pero ha tenido como, la ley ha tenido algo de barrera, de confusión acerca de si cubre o no cubre, cambia con respecto al estado. Hay estados que cubren unas cosas y tienen unos márgenes diferentes. Entonces, de cierta manera, está más ligado al regulador, o es decir, a la aseguradora, qué le cubre y qué no le cubre dependiendo del estado como tal, ¿sí? Entonces, por ejemplo, en algunos estados, si vemos en New York, el rango para poder criopreservar está aproximadamente 21 a 44 años, o sea, tiene un rango de edad. En otros países como Illinois, tiene un rango también que tiene que tener 14 a 45 años. Y en otros países no está ni siquiera regulado, no tiene restricciones en otros estados, perdón, no tiene ni siquiera restricción de edad. No hay restricción de edad con respecto a cuándo puede criopreservar. Entonces, de cierta manera, hay un cambio variable de información dependiendo obviamente del estado donde está el paciente. Entonces vemos en esta gráfica, por ejemplo, cuándo comenzó en los diferentes estados, en los estados que está cubierto en Estados Unidos, ¿sí? Digamos cuándo se comunicó a la aseguradora que podría cubrirlo, cuándo comenzaba a ser efectivo, que fue, sigamos, diferentes rangos de fecha, 2018, 2022 comenzó ya a ser el beneficio para los pacientes que están asegurados. Y una comunicación de regulador o tener una fecha de comunicación al paciente, y a su vez también hay unos diferentes planes dependiendo del estado, que podían tomarlo de forma individual o en grupos pequeños o en grupos, por ejemplo, grandes de mayor de 50 personas. Si vemos con respecto a los diferentes planes que cubrían la criopreservación, la mayoría, este último que dice Medicaid, no incluye la mayoría en los diferentes estados como California, Colorado, y solamente en Illinois está incluido. Este es muy importante porque es el único de los seguros médicos estatales que está cubierto a personas de bajos ingresos. Los demás son usualmente personas que pueden pagar y que incluyen las técnicas de criopreservación, ¿cierto? Entonces, todo esto, digamos que puede hacer una variación muy importante y digamos que el paciente no tiene claro o se enreda con respecto a qué estado está y qué le incluye y qué aseguradora tiene, ¿no? Además de eso, hay leyes en los diferentes 10 estados en el cual algunos definieron cuando había infertilidad iatrogénica. Iatrogénica es que un paciente pues, le había dado cáncer, por ejemplo, y le tenían que hacer quimioterapia o radioterapia. En algunos ni siquiera está, de cierta manera, estipulado cuando era infertilidad iatrogénica. Algunos decían que las diferentes sociedades como la ACRM, la ASCO, la ACOG, tenían que decir cuál paciente tenía infertilidad iatrogénica, o sea, las guías de ellos, y cuál le incluía o la aseguradora no. Entonces vemos que algunos no tienen una información específica, por ejemplo, en California y Colorado con respecto a la preservación de óvulos. En fin, es muy variable. Entonces eso hace que la mayoría de pacientes de Estados Unidos, si le cubre las aseguradoras, depende del estado, depende del plan que tengan, es decir, es bastante complicado en Estados Unidos. En Europa, la congelación de óvulos sin fines médicos, es decir, la mujer que estaba preocupada por el tema de la edad reproductiva, no está permitida en algunos países. Entonces, por ejemplo, en Austria, en Francia, Hungría, Lituania, Malta, Noruega, Serbia y Eslovenia, no se permite solamente por fines, por ejemplo, pacientes oncológicas o con alguna condición de salud que necesitarían criopreservación de óvulos, pero no por edad, no porque desean congelar. Está permitida solamente en algunos países, de todos los países europeos como Alemania, Suiza y España. Ahorita ya en la siguiente diapositiva veremos una gráfica más ilustrada de cuál permite y cuál no permite, y cuál cubre y cuál no cubre, ¿cierto? Y todo esto también está basado en algunos factores sociales, religiosos, legales de cada país, ¿sí? Entonces, en esta gráfica, que es una gráfica bastante extensa de la ESRE, con respecto a los países de la Unión Europea, los países europeos, vemos que está la criopreservación de óvulos, la criopreservación de embriones, de tejido ovárico incluso. Y vemos como la mayoría, hablando de pacientes que deseen preservar fertilidad o preservar óvulos por razón oncológica, es decir, por cáncer, está permitido. Entonces vemos Austria, Bélgica, Croacia, Francia, Italia, en general la mayoría permite, algunos con algunas restricciones. Y ya si cubre o no cubre los costos el Estado como tal, es variable por país. Si vemos en la gráfica, en la columna que está siguiente, a si es permitido o no, algunos países cubren, otros no cubren, y es muy variable, ¿no? Vemos que Italia cubre, Irlanda cubre, Alemania no cubre, Francia sí cubre, por ejemplo, Dinamarca sí cubre, y que en algunos países como Bélgica y Bulgaria hay un reembolso, dependiendo obviamente de las condiciones y seguramente la condición clínica y lo que se asesore, puede haber un reembolso del dinero por parte del Estado a las pacientes que hicieron criopreservación, ¿cierto? Con respecto a la preservación de óvulos por enfermedades benignas, por ejemplo la endometriosis, en Europa es permitida en la mayoría de países la criopreservación de óvulos o incluso tejido ovárico y de embriones. Pero vemos que República Checa, hablando de la criopreservación de óvulos y tejido ovárico, que es lo que concierne más al tema de hoy, no está permitida. Pero en la mayoría sí está permitido. Y también pasa lo mismo con respecto a si el Estado provee o no provee los costos a los pacientes con respecto al gasto. Vemos que hay muy variable, algunos cubren, otros no cubren, como está en la gráfica siguiente a lo permitido, en la columna derecha, a la derecha siguiente, y algunos obviamente también hacen reembolso a los pacientes, ¿sí? Con respecto a hombres transgéneros que deseen preservar fertilidad, vemos que incluso ya el hecho de preservación de óvulos es mucho más variable si es permitido o no permitido en los diferentes países europeos. Países como República Checa, Georgia, Hungría, Lituania, Serbia, Eslovenia, Turquía, no permiten la congelación en hombres transgéneros, ¿no? Y los otros países que vemos en la gráfica sí lo permiten. Entonces es muy variable. Aquí ya comienza a cambiar un poquito con respecto a las anteriores. Y también el hecho que el Estado cubra a nivel económico, vemos que ahí en este caso la mayoría no cubre, solamente Dinamarca, Francia, Holanda, Noruega y Portugal, bueno, y España y Suecia son los que al final del día cubren el Estado a los hombres transgéneros. Incluso si vemos la criopreservación de tejido ovárico también es muy variable, menos permitido todavía y menos cubierto incluso que la criopreservación de óvulos, ¿no? En este tipo de pacientes. Ya con respecto a la preservación de fertilidad o de óvulos relacionado a la edad reproductiva, a la pérdida de edad reproductiva, ahí cambia la circunstancia. Vemos que la mayoría de... Hay muy variable, pues, sí, no todos, pero la mayoría, hay un buen número de pacientes que no permiten la criopreservación por edad, lo que estaba en la primera gráfica de los países europeos. Austria no permite, Lituania, Francia no permite, Serbia, Eslovenia no permite. Y que en este caso de preservar la fertilidad solamente por edad, ya el Estado como tal, y ahí sí son todos los países, no cubre los gastos. Eso le toca a la mayoría de cubrirlo en forma privada, ¿no? En esta gráfica, que también es variable dependiendo obviamente el país donde estén en Europa, cambia algunas leyes o recomendaciones con respecto a, por ejemplo, el tiempo de duración de estar los óvulos guardados o el tejido ovárico. Algunos países no tienen límite, en otros dan una extensión de 5 a 10 años, otros 10 años, varía mucho dependiendo del país. Si vemos en la gráfica también el límite de edad, algunos países no tienen límite para poder congelar óvulos o tejido ovárico, otros por debajo de 50, 48 o 42 años es permitido la congelación de óvulos. Esto también puede variar mucho en los diferentes países donde estén en Europa, ¿no? Aquí vemos la otra gráfica que también Por ejemplo, en la siguiente en Rusia, en España, en Suiza, no hay límite con respecto a la edad que se pueda congelar óvulos. Hablando de los países más cercanos, como es España, entonces en España está contemplada una ley, o se contempló, perdón, una ley en 1988, la cual no autorizaba la criopreservación de ovulitos, pero esto cambió en el 2003. Y el decreto, el Real Decreto 120 del 2003 cambió, y en el cual ahí cambió estas políticas y en el cual regulaba de cierta manera este tipo de técnica de criopreservación y permitía la fecundación de óvulos y la criopreservación de óvulos y tejido ovárico. Todo esto obviamente relacionado con técnicas de reproducción asistida, y se volvió a validar en la Ley 14 del 2006, en el artículo 11, con respecto a congelación de gametos, en este caso óvulo y semen, ¿no? A su vez, en España la congelación de óvulos está cubierta por la Seguridad Social en caso de pérdida por enfermedad, pero no está cubierto por motivos sociales. Tampoco está cubierta, como está en las gráficas anteriores, de la R con respecto a edad reproductiva, por ejemplo. Entonces, en este caso, la paciente tiene que costearlo, aunque sí está permitido, pero tiene que costearlo usualmente de forma privada. En Israel, y trae este país porque es de los que más tienen cobertura con respecto a técnicas de reproducción asistida, en el 2009, digamos que en Israel National Bioethics emitieron unos 3 documentos en el cual daban unas directrices con respecto a las técnicas de reproducción asistida. Dos directivas del ministerio dieron con respecto a dar permiso y regular la vitrificación de óvulos, y también hicieron una modificación en el 2009 con respecto a la fertilización in vitro. Entonces, lo que decía más que todo era que permitía la extracción de óvulos de una mujer que no está recibiendo tratamiento de fertilidad y que desea preservar la fertilidad por razones como la edad. Entonces, ¿qué le permiten? 4 ciclos de captación o la recuperación de 20 óvulos, o lo primero que sucediera, congelar los óvulos por 5 años inicialmente, y la paciente podría prorrogar cada 5 años si hacía una solicitud. Y la INBC también permitía o daba un rango de edad de 30 a 41 años para poder hacer la criopreservación de óvulos, ¿sí? Y que estos óvulos se podían dejar guardados y solamente fecundar e implantarse hasta los 54 años. Israel es uno de los países que más tiene una cobertura, y seguimos en las gráficas anteriores, tiene 5.500 ciclos por millón de habitantes de técnica de reproducción asistida. Y hablando de criopreservación, quizás no cura del todo el estado, el gasto, como de pronto sí una fertilización in vitro, que sí lo hace, pero sí, de cierta manera, hay unas organizaciones israelíes de salud que subsidian a las pacientes que no puedan por costos hacer criopreservación de óvulos. O sea que es uno de los países que tienen más cobertura con respecto a criopreservación. Entonces, yo creo que con esto hemos tratado de cubrir, y espero que le haya dado una información valiosa, cómo se comportan los diferentes países del mundo con respecto a política, con respecto a si qué cubre y qué no cubre, si el Estado paga o no paga, o las aseguradoras pagan o no pagan, y le ayudan económicamente a las pacientes en el mundo. Creo que todavía hay un gran trabajo que hacer en el mundo, ni siquiera solamente en Colombia, sino en el mundo, con respecto a que hay una conciencia general con la congelación de óvulos, especialmente porque nuestras mujeres actualmente no están buscando hijos a los 20 o 30 años como en otras décadas. Ahorita mismo las mujeres buscan hijos a los 37, 38, 39 años. Es más, en algunos estudios de este tema de criopreservación de óvulos, en Europa las mujeres no consultan a los 30 o 35 años, consultan a los 37 años o más a criopreservar óvulos. Y la recomendación es que ojalá consultara antes de los 35 años para congelar óvulos. Creo que nos falta más trabajo a nivel de los médicos, de los clínicos, de políticas estatales, con respecto a concientizar a la gente y a las mujeres en general de preservar su fertilidad, especialmente si no están contemplando en un momento de la vida de tener bebés y si lo quieren postergar a futuro. Recuerde que esto no es un plan A, es un plan B. Para si una paciente o una mujer tiene una edad importante y no puede de forma espontánea quedar embarazada, pues tenga una opción más, por lo menos otra opción que nos permita a nosotros como clínicos ayudarle a futuro y que realmente pueda ser mamá o lograr su sueño, aunque le toque postergarlo. Esperemos que las políticas cambien un poco en algunos países y que algunos países de Latinoamérica, como Costa Rica quizás, cambien sus políticas con respecto a la fertilización in vitro y que en nuestros países latinoamericanos tengamos unas políticas que incluyan más técnicas de criopreservación, incluso técnicas de reproducción asistida en general y que ojalá ayuden más a nuestros pacientes al tema especialmente de costos, ¿no? Bueno, este es nuestro centro de fertilidad en general y yo le agradezco mucho hoy la atención de esta charla. Espero que haya servido mucho la información y espero que tengan un feliz resto de día.